Good morning, everybody. Welcome to the 2019 OHDSI Symposium. I'm excited to see, I am so excited to see so many people here joining us for the next few days. And we're trying something a little bit different this year with having our opening day here. Have tutorials, which we're going to be doing today, and then we've got a very special event this afternoon after our tutorial, and then we'll have a wonderful symposium tomorrow and additional tutorials on Tuesday. Today, you guys are all here to learn about cohort definitions and phenotyping. Raise your hand if that's what you think you're here for. All right, good. All right, good. So I'm not going to scare anybody away yet. So I'm really excited to be participating in this course alongside my fellow faculty, Chris Knoll and Kong Lu. We are going to be doing something different this time that we've taught this course, and I'm really actually excited about it. In the last year, within the OHDSI community, we've seen tremendous progress in the area of phenotyping. On a bunch of different dimensions. We've really matured a set of tools for defining phenotypes and being able to run them against the OMOP Common Data Model. We've really matured our thinking about what it actually means to have a gold standard phenotype process to define phenotypes. We've made tremendous advancements in how we actually think about evaluating phenotypes. And we also have been developing very novel tools to facilitate the process of creating phenotypes. And much of this work has actually been published in the scientific literature here in 2019. And whereas very oftentimes some of this work has been the work that it started as a poster at the OHDSI Symposium only a couple years ago. Now it's actually become mature solutions that we're now proud to be teaching you to actually be using in your own research. And so today during the tutorial, we're going to be talking about scientific best practices for how to think about what a cohort definition or a phenotype is. You all are going to get to experience playing with Atlas as a tool for defining phenotypes. Raise your hand if how many of you have played with Atlas before? Okay, probably about like a half of you. That's great. So we're going to be able to really dive in deeper on how to create phenotypes using the Atlas platform. And we're going to show you some of the advances that we've made in that space. We're also going to be teaching you how to use a tool called criteria to query. How many people are familiar with that? Like 3 hands. Everybody else is looking around like, what is this? So criteria to query, I'm extremely excited about. This is work that's been led out of Chunhua Wang's lab, and Kong's going to be walking you through the details. But in fact, we've developed something that I think is a pretty remarkable innovation. You can actually type a free text description of your inclusion criteria, and we've developed a natural language processing module that can actually read that free text and turn it into a cohort definition that's fully compliant with the OMOP CDM and runs in Atlas. And so you're going to get to actually see something that has been a cool idea that was presented as an initial poster a couple years ago, has now been published in JAMIA, and we sent out the paper, and you're actually going to get the experience to play with that tool yourself. The other big innovation that we've had this year is we developed PhEvaluator. This was also something that started as a humble little poster, I think a couple years ago at the OHDSI Symposium. But PhEvaluator is the idea to be able to apply probabilistic models to be able to estimate the sensitivity, specificity, and positive predictive value of any phenotype algorithm. This is work that's been led by Joel Swerdell and that George Ripsack and I have been participated in. Unfortunately, Joel is under the weather today. He is supposed to be here to actually take all of the glory and credit for the amazing work that he has done. So I'll be stepping in on his behalf to present his work and to show you all how you can actually use PhEvaluator to evaluate your own phenotypes. The other thing that actually I'm most excited about for this class is you're going to hear from George tomorrow that one of our key themes in OHDSI for 2019 has been the idea of continuous evaluation. The idea that what we're trying to do is not just advance science, but try to learn, are we actually making progress at getting better at the science that we're doing? And so we've decided to run an experiment throughout today's class. And specifically, because you are going to be introduced, you're going to be, for many of you, you're going to be refamiliarizing yourself with Atlas. And for most of you, you'll be introduced to criteria to query. We're actually going to run an experiment during our exercises today to actually try to quantify how much better are we getting as a community at designing phenotypes. And so you all are going to participate in a randomized experiment today where you are going to get to experience these tools, and then we're going to get to learn from your experience to figure out how we as a community can actually advance the science of phenotyping. So that is my plan, and we've actually deliberately blocked some time this afternoon to talk about where we should be going as a community in the phenotyping space. We do have lecture material that we're going to be going through, but I would, as much as possible, like for this to be an open conversation. So if anybody has any questions or comments or challenges anywhere along the way, please do raise your hand and challenge. I will point to some of the areas where, as a community, I think we're still trying to form our collective opinions, and encourage you all to engage in those debates as well. So, does that sound good for today? Yeah. Yep. All right. Well, so let's dive in, and I'm going to try to keep to task with time. All right, we're doing okay. All right. So I'm going to kick this off by providing some of the basic theories and principles as we have been thinking about them in the OHDSI community. Disclosure, so I am an employee of J&J. I am also a professor at Columbia. I don't think any of the slides I'm going to talk about have anything to do with what I'm doing at J&J, but if anybody asks any questions about creating cohorts about some products at J&J, then I'll try to at least remember that we make that product and tell you about it. I mentioned our agenda, so what I want to really start with is just trying to motivate why we actually need to standardize the cohort definition process. Chris is going to walk you through defining a cohort in Atlas, and you're going to get to see him and follow along as he demos an example of being able to design a cohort in Atlas. Then Kong is going to walk you through how to define a cohort using criteria to query. We've got a big chunk of the afternoon listed on the agenda where you all are going to actually get to do this yourself. And we've got a team of teaching assistants that are going to be around to help you. So what our real goal is that not just that you learn the ideas, but that you come out of today feeling comfortable that you yourself can define phenotypes using the OHDSI tools. We're then going to talk about how to evaluate phenotypes. And then I want to spend some time talking about the future research that we need to do in this space. All right, so first to motivate this, and actually just we sent 2 papers out to read. We sent you out the criteria to query paper and the fee evaluator paper. Raise your hand if you received them. All right, so only most people say that they've received. Okay, how many of you read them? Okay. Some set of the people who received them read them. I saw a couple hands who didn't receive them but read them. That's amazing. Maybe they got one of the OHDSI tweets about the papers and read them at some other time. One of the papers that we didn't send out, actually I'm just curious, how many of you have attended an OHDSI tutorial in the past? Raise your hand. Wow, actually only about raise your hand super high. Actually, this is really interesting to me. Okay, so only about a third of you. So how many of you have attended an OHDSI symposium in the past? Okay, so half of you, so raise your hand if this is your first OHDSI event. Holy, wow, this is awesome, cool. That is awesome, that is great, okay. Well, so I'm not gonna spend a lot of time talking about how awesome our previous events were because or I guess I should just tell you that they're pretty awesome and that you're lucky to be here. That's true. You can watch all of the crazy things that I've done on YouTube. that is, so that's great. So if you do watch one of the prior tutorials on YouTube, you'll notice that many of the other tutorials we offer, including patient-level prediction and population-level estimation and the OMOP Common Data Model class, we have a single paper that we commonly use as a reference to motivate things, simply because we think it's a good example of current best practice in the field, and we think it's a nice illustration of the type of work that I think we should all try to aspire to do. And it's this paper that was published by David Graham out of the FDA, entitled Cardiovascular Bleeding and Mortality Risks in Elderly Medicare Patients Treated with Dabigatran or Warfarin for Non-Valvular Atrial Fibrillation. This was an observational study that used the U.S. Medicare Administrative Claims Database to evaluate the comparative safety and effectiveness of these two different anticoagulant treatments, and examined and showed differences between these treatments that might be important for patients and providers who are trying to manage atrial fibrillation. We use this example not for any particular reason other than it's a recent, nice, high-profile paper that received some attention, and we've used this to kind of critically break down what are the elements that go into an observational study. And for purposes of today's class, if you're interested in this paper, we'll provide the link, and you can just look it up yourself. The details about this paper aren't necessarily the clinical details aren't necessarily important, but what we're going to focus on in this class is actually just to try to motivate that to do any study, including this very nice paper, it starts with a foundation, and that foundation is the ability to define cohorts clearly, unambiguously, and accurately. And specifically, once you have cohort definitions, there's a lot you can do with them. We've been using this analogy of thinking about the Legos that we are building. The cohorts basically provide us the Lego blocks that allow us to do any type of observational research that we might want to do, whether we're trying to conduct clinical trial feasibility, whether we are trying to just characterize a cohort, whether we're trying to understand the incidence of an event, whether we're trying to actually examine some causal effect of an exposure, or whether we're actually trying to predict which patients are at risk of some outcome. No matter what type of analysis that we've come up with across the OHDSI community, the input to every single type of analysis is a cohort. And the consequence of that, and if anybody takes Peter's prediction class on Tuesday, you'll see this, is we've actually gotten to the point that we're pretty good at running analysis now in the OHDSI community. We can run fancy patient-level prediction models in minutes. We can do causal inference with advanced statistics, but every study lives or dies on the ability to define the cohort definitions correctly. And as we've been teaching the other classes, including population level estimation and patient level prediction, what we find is we want to spend our time teaching all of the cool advances in statistics, and time again it all comes back to, can we make sure that we've defined our phenotypes correctly? Can we actually define our exposure population and the population at risk? Can we define our outcomes in some way that we're comfortable with it? And what we realize time and time again is that if we can't get the cohort definition phenotyping problem right up front, the rest of what we do, it pales in comparison of what's necessary for us to achieve OHDSI's goal of generating reliable evidence. So, with this paper, this happens to be an example of a population level effect estimation study examining two different treatments, warfarin and dabigatran, for an indication of atrial fibrillation and looking for various outcomes, including cardiovascular events, bleeding, and mortality. And when we think about that as a motivating question, we can ignore all of the fancy statistics that have to go into answering that, and instead we can ask some very basic questions like, how would I go find people who take warfarin in my population? How do I define atrial fibrillation? What is a bleeding event? These are the questions that we're really going to dig into today in our phenotyping class. So in the Graham paper, if you were to pull it up, you're going to see a variety of different outputs that exist in the paper. And I would say, by and large, these are the kinds of outputs we would expect to read in pretty much any well-done observational study. For example, there's a table 1 in this paper that takes two populations, the people who initiated treatment on dabigatran and the people who initiated treatment on warfarin, and it provides a baseline characterization of who are those people. It breaks them down by demographics such as age and gender and race and ethnicity. It looks at their medical history to look at prior conditions, prior medication uses, prior surgical interventions that have occurred. There's some risk scores in there in terms of their risk of having a their risk of having a stroke, their risk of having a bleeding. These are baseline characteristics that are described about this population. And most papers have something like this that start off a paper just to say, who are the populations that I'm studying? And yet, while we see all of these words over here, then all of these words that describe all these labels, up top we just have these simple labels that just says dabigatran and warfarin. What we're going to focus on today is all of the work that's actually going to have to be baked in to create the columns that are going to allow us to fill these rows in the table. So you can't create a good baseline characterization of a population unless you actually have defined the population. And in this particular study, we're looking at two different cohorts: the target cohort of people on initiating dabigatran, the comparator cohort of people initiating warfarin. And once we have those cohorts, there's a variety of different analytic strategies that we can apply to them, including, for example, producing your standard table 1 that you need for pretty much every paper you're ever going to publish in observational research. So that, if for no other reason for you to pay attention today, it's because you need to have a table 1. Now, table 2 in the Graham paper actually takes those same two cohorts and it examines the incidence of outcomes that occurred. So specifically, it looks at these primary outcomes of ischemic stroke, major hemorrhage, acute myocardial infarction. And what you could see in their table 2 is that they provide the number of events that occur. So here you see in the dabigatran cohort, there was 205 people who had an ischemic stroke. And so here, what's interesting is that we still need to reuse the same cohorts we used for table 1. Namely, we have a target cohort of new users of dabigatran. We have a comparator cohort of new users of warfarin. But now we have a new entity that we need to be able to define, namely our outcome, ischemic stroke. Which raises the question, how do we define ischemic stroke? And how do we not just identify the people who have ischemic stroke, but identify when did the ischemic stroke actually take place? Because somehow I need to be able to intersect the people who initiated dabigatran with the people who've had an ischemic stroke and find out that the ischemic stroke occurred during some time at risk relative to when I was exposed to dabigatran. And so this typical table 2 that you're probably going to have in just about every paper that you'll ever publish too. Now I need 3 cohorts. I need a target cohort, I need a comparator cohort, and I need an outcome cohort. And all of these numbers are predicated on us feeling good about those 3 cohort definitions. Now, question. Yeah, so in this particular case, they've defined some time at risk relative to the start of treatment, and they're going to look for the event after that. And I'm going to go through a little bit greater depth later. But one of the things I want you to think about is, let me back up. Very often when we think about studies, we don't think about defining cohorts or cohort definitions or phenotypes, but instead we just are looking for binary indicators, like we found the dabigatran people, and then we just ask a question: did they have an ischemic stroke? Yes, no. What we're going to try to teach you as you're thinking about cohorts today is to think about the fact that creating a cohort of people who have ischemic stroke, that actually is a population that probably is valuable for you to define and characterize and understand, independent of the cohort of people that are new users of dabigatran. And the reason that that is powerful is because if we can create cohorts for each of our exposures and cohorts for each of our outcomes, then we can actually just look at the intersection of those populations to be able to produce characterizations like this. So instead of thinking about creating a data set where we find the exposures and just say, did people have an event, yes, no, instead we can think about who are the people who have the exposure, separately, who are the people that have the outcome, and then for an analysis like this, we can say, who are the people who have the exposure and the outcome during some time frame that I'm interested in. And by creating these building blocks of cohorts, we can mix and match them in any sort of way to produce reliable summary statistics like this.
So that sounds like we have to create a different set of cohorts, right? Exposure for treatment, right? Having or not having treatment, interest. And also we have to define a separate cohort who develop an event we are interested in, right?
Yes, so just to repeat the question for the audio. So the question is, so it sounds like in this particular case we would have to define 3 different cohorts. We'd have to define a cohort of people who are on the target drug. We'd have to define a cohort of people who are on the comparator drug. And we'd also have to define a cohort of people who've had the outcome. And that's exactly right. We're going to go through the...
Why do we do that instead of just creating 2 different cohorts and following them up in an imaginative way to see if any of those cohorts would develop the disease of interest?
Yep. So the question is, so why do we have to create this outcome cohort? Why don't we just like follow these people and just say, yes, no, they had the event? And what we'll try to go through is that to define an event actually requires sophisticated logic to actually identify which are the people who experienced the event and when did the event happen and when did the event stop. And once you actually sit down and define those elements of that, what you in fact have done is defined a cohort. And the power of this is that instead of only examining the people on dabigatran and looking forward for the subset of those people who had ischemic stroke, if we could define a cohort for ischemic stroke, now I could use that cohort not just for this one study of dabigatran, but for any study I'm ever going to do on ischemic stroke. And similarly, if I can create a cohort of people with dabigatran, I could do a study not just on ischemic stroke, but I could examine any other outcomes for that particular population. So by building these as building blocks, we're going to be able to actually put them together in any sort of studies that we might be interested in conducting. So also in this table too, in addition to the incidence, they produced hazard ratios. So they conducted population level effect estimation to produce an estimate of these outcomes. And indeed, in the OHDSI community, we spent a lot of time creating population level effect estimation tools. And key outputs that we would want to generate, such as a hazard ratio, are things that you can only do if you defined a target cohort, a comparator cohort, and an outcome cohort. So the bottom line for this is if you want to do some research where you do some clinical characterization, let's say you want to examine disease natural history or you want to look at treatment utilization patterns. Well, if that's your desired output, the input for that is going to be a target cohort. That is, you're going to define a set of people who satisfy some criteria for some duration of time, and you're going to use those people to produce your characterization. And to do a characterization of 2 populations simply means that you just need to create 2 cohorts, because we should be able to build the same analytics routine and pass in as an input different cohorts. If I want to produce that table 1, I should have one piece of code that can produce all of the baseline characteristics of a population and just run that code twice for my 2 different inputs. I don't need to figure that out separately each time. Interestingly and importantly is that outcome cohort, ischemic stroke. One thing that's not in the Graham paper and not in most papers that we see is just a characterization of the event itself. Independent of exposure, I just might want to understand, what does ischemic stroke look like in the world? Who are the people that get ischemic stroke? What are their baseline characteristics? And it turns out because that outcome cohort also could serve as the same input to the same clinical characterization tool. If we have a tool that does characterization on cohorts, then that means that all we need to do is define different cohorts to produce different characterizations. So I should be able to recover the same kind of information about new users of warfarin and dabigatran as I could about people who have just experienced an ischemic stroke. But if I've defined these cohorts, a target and a comparator and an outcome, I can actually use these cohorts in conjunctions to perform a variety of different analyses. So for example, that table 2 that provided incidence summary, I can simply find the people who've had a target cohort, the people who've had the outcome, and actually produce some sort of an incidence of those outcomes occurring in the population during some time at risk. And I can use the exact same inputs to perform a population level effect estimation study. So if I actually wanted to try to produce a causal contrast of whether or not warfarin or dabigatran has a higher risk of bleeding, I can use the exact same inputs that we're defining and pass it into a different analytic procedure. And if I'm interested not just in answering the question, does dabigatran cause bleeding, but asking which patients are going to experience the bleed, well, it turns out that that's a different analytic procedure. That's patient level prediction, and yet it uses the exact same inputs. So what we're going to be focusing on today is the idea of creating inputs. And the reason why we actually deliberately chose to make this course the first day is many of you guys are going to be taking tutorials on the Tuesday. And in the Tuesday, pretty much every course is going to say, so you know how to create cohorts. Those are our inputs that we're going to pass into all of our analysis procedures. Okay. So just to be clear to motivate this is not just a conceptual idea. That Graham study, if we wanted to produce a cohort characterization, just like the Graham study, the Atlas tool that you're going to learn takes inputs of cohorts and produces an output of a characterization. And it can produce everything that's in that paper in a couple clicks of a button. If you want to produce an incidence rate summary, Atlas actually does this too. It takes an input of target cohorts and outcome cohorts, and its output is actually a breakdown of the incidence, stratified in whatever way that you want. Atlas will design estimation studies for you, and all you're passing in is an input of your target and comparator group. And the output of that would be all of the artifacts that you would expect to see in a full-fledged publication in terms of all of your study diagnostics and your estimates. And the patient level prediction is also something that Atlas can do. So our focus here is not about performing the analyses. You can learn that in all of our subsequent tutorials. The focus here is that if we can define the inputs correctly, you can hopefully trust me that all associated outputs that you might be interested in generating evidence from the Odyssey community are going to start with the materials that we're building today. So let's get into actually defining these cohorts. So one of the most interesting conversations that's taken place in the Odyssey community this year is a forum thread. Let's see, I'll just pull it up in case you guys missed it for some reason. This forum thread that started back in May of what is a phenotype in the context of observational research. And who knew we were going to hit such a nerve for people, and people were going to have lots and lots and lots and lots and lots and lots and lots of opinions about this, and lots of opinions and lots of opinions and lots of opinions. And actually, it's been extremely valuable to realize that as a community, we are all struggling with kind of the same problem. Whether you come from informatics and you call it phenotyping, or you come from epidemiology and you call it a cohort or a population, or you don't have a name for it, but you kind of have an idea of what this thing is that you're trying to do. We're all struggling with the same basic problem, and what we realized as a community is we've got to try to ground ourselves on some sort of language to at least be able to speak with each other about what we're doing. As a result, and there's been tremendous work that's been led by Aaron Potvin and others, we have in the OHDSI community a work group that's focused on trying to establish standardized processes for creating phenotypes. I would encourage all of you to consider joining and participating in that effort. And as part of that effort, we are trying to at least ground ourselves as a community in thinking about how do we define these things. So I'm going to go through a definition of phenotype that I'm going to use for purposes of today's tutorial. I do not want you to think that this is the definition, because the community right now is actively wrestling with these very questions as they're going on. And I think that that's actually the right thing to be doing as a community. But I do want us to ground on some language that we can at least use with each other as we're going through and learning these tools. So I'm going to borrow one out of, usually if I have a default thing and I don't know what to do, what I do is I go into PubMed and I search for George Ripsack, because usually he's got some sort of an insight for me. And he actually did publish a paper a couple years ago entitled High Fidelity Phenotyping, Richness, and Freedom from Bias. And in that he provides a definition of phenotyping that I'll share with you just as a way to start thinking about this. He describes that a phenotype is a specification of an observable, potentially changing state of an organism, and as to be distinguished from a genotype, which is derived from your genetic makeup and therefore constant. The term phenotype can be applied to patient characteristics that are inferred from an electronic health record. And the goal is to draw conclusions about the target concept based on the raw EHR data or claims data or any other clinical relevant data. And therefore, phenotype algorithms, those are the algorithms that identify or characterize the phenotypes. They may be generated, and there's a variety of different ways to do that, whether that be domain experts or knowledge engineers or machine learning algorithms or whatever it might be. Now, things that I want to highlight about this as it relates to this definition. So one is we're going to be talking about things that are observable. And where are we going to observe things? We're going to observe data about patients based on whatever data is available in the OMOP Common Data Model. So if we have observations about patients, we are going to use those observations to find patients. The other thing that's also very important here is this idea that the potentially changing state of an organism. So it is very, very common when I read the literature and look at papers that I see that a cohort is defined as people who have a disease, people with diabetes, but it's actually, or people with a flu or whatever it might be. But it's important to realize that that is not a constant state for an individual. There's a moment that a person doesn't have diabetes. There's a moment that that person may develop diabetes, and maybe with diet and exercise, there's a moment that they would no longer be classified as diabetes. And this notion of having a potentially changing state means that a cohort or a phenotype is something that actually is going to vary over time. That you could belong to a phenotype at some moment in time and not belong to phenotype at some other moment in time. Second thing that I'm going to highlight is the distinction between the phenotype and the phenotype algorithm. So the phenotype is that clinical idea you've got in your head about what you want to study. It is not something that actually is defined in code that you're applying to your database. It's an idea that's actually defined in your head. If I say people with diabetes, I have some clinical idea about what that means. And actually, one of the things that we're discovering and is debated at active on the OHDSI forums is that idea that different people have different ideas about what a disease means is actually one of the fundamental problems that we're challenged with. If I say people with diabetes, do I mean people who a clinician has clinically diagnosed with diabetes? Do I mean people who have a hemoglobin A1C greater than 6.5? Do I mean people who are suspected to have diabetes enough such that some clinician prescribed them metformin? Those are different ideas about what diabetes is or isn't. None of them are right, none of them are wrong. They're just different. And yet we use language as a way to simply describe ideas and say, oh, people with diabetes. What's important is actually that the phenotype is that observable state we're trying to represent, and it's important for us to, as much as possible, be precise in the clinical description of the idea that we want to go after. Because what we're going to be doing is we're going to be translating that clinical idea into a definition that we can run against a database, which is the phenotype algorithm, the cohort definition. We'll be using those phrases interchangeably throughout today. And the cohort definition now is not a clinical description of anything. It's an operational definition of what observations am I going to go look for in the database to identify people that I hope are consistent with that clinical description that I started with. And so there's a lot of, this is a complex game of telephone that goes on in having lots of steps of translation. And at each step of that translation, there can be some information loss. But it actually starts with the idea that you all, as researchers, are starting with an idea in your head. And whatever that idea is, whatever your preconceived notions of that clinical idea is, it's very important for you to be able to describe and articulate exactly what you have in your mind for that idea, because that is the starting point to think about how we can go find those patients who meet your clinical idea by looking in the data and identifying the observations. Now there's two primary approaches to phenotyping, and we're going to actually, for purposes of today's class, we're going to focus on one. There's rule-based phenotyping, which is the idea that you create some sort of heuristic that defines that a person either belongs or doesn't belong to a phenotype based on some set of criteria associated with their observations. And Atlas is an example of a tool that implements rule-based heuristics. What you're going to see from criteria to query is us applying the inclusion and exclusion criteria from clinical trials. And in fact, clinical trials are all using rule-based heuristics. Anytime you see a list of inclusion and exclusion criteria and a person either belongs or doesn't belong, that's a rule-based heuristic. For today's class, we're going to focus on that, and I would say in the field at large right now, that still is representing well over 90% of what's actually being done in current practice. But I don't want to lose sight of the fact that, as George highlighted in his paper, and as we're innovating in the OHDSI community, there's also the idea of probabilistic phenotyping. Instead of saying that a person belongs or doesn't belong to a particular phenotype, we could instead say, what's the likelihood that someone belongs to it? So it's not that I either have diabetes or I don't. There's some probability that I have diabetes at any moment in time based on what you've seen about me. And in the OHDSI community, we've been innovating on this idea of how to actually create probabilistic phenotypes. Juan Banda at Georgia State has been innovating in this space, and in prior tutorials, he's actually shown how to use one of the tools that he developed called Aphrodite. Just in the interest of time for today, we're not going to cover that, but that is not because we don't think that that's a cool and important idea. Quite the contrary, we think it's a very exciting area. But just because you guys probably want to end at 5 o'clock to go to the reception, we're going to focus on rule-based heuristics today. So, I mentioned that the cohorts are the Lego bricks to all of our analyses, but now we actually need to look at the Lego bricks that make up cohorts. And these are each of our observations that we would actually capture in our patient-level data. And to a large extent, the way that we've been trying to conceptualize this is to think of the OMOP common data model as our model that is representing all of the clinical observations. And so each row of data in the OMOP common data model, that's actually our smallest level of a building block, or our Lego bricks that we could use. And what a phenotype algorithm is going to be is some combination of looking to see, for a given patient, do they have some collection of clinical observations across any of the domains in the OMOP common data model. So typically, when we look at phenotypes, you will see that we're looking at conditions and drugs and procedures and measurements and observations and visits. And these are the kinds of domains that we have in the OMOP common data model, containing observations that are captured for a given individual. And very often, when we want to define a phenotype, we're actually probably going to stay inside of a particular domain. For example, in conditions, we may have observations that exist in our data of diagnosis codes. You may have an ICD-9 or ICD-10 code or a K code in your source data. But the clinical idea that you have in mind might not be represented only by one code, but might actually be some collection of codes that you're looking for. To go back to the diabetes example, if I'm interested in people with diabetes, there are many different codes for type 2 diabetes, with and without complications, with associated neuropathies and other disorders. And each of those codes may be choices that I would make to say, if I want to find all people who have diabetes, that might mean that I'm interested in finding any person who has any of these small-scale building block clinical conditions that are observed in the data. Very, very often, we see phenotypes developed where the clinical idea belongs to one particular domain, and therefore the observations used to define that clinical idea also come from the same domain. But in fact, for many cohorts that we might be interested in, there is no reason to think of that as a constraint. If I want to define diabetes, I don't need to only look for diagnosis codes of diabetes. I could also say, I'll look for diabetes, I'll look for the condition of diabetes, or I'll look for drugs that treat diabetes. Or I'll look for measurements of hemoglobin A1C with values greater than 6.5%. A clinical idea can manifest as clinical observations across multiple different domains. And the task of a cohort definition is to simply figure out how are we going to assemble these Lego bricks from all of the different domains that are necessary to be able to define the set of people that we want to find and distinguish them from the folks that we don't think we have in mind for our clinical idea. There was a nice paper that was published a couple years back now that actually in JAMIA, that what it tried to do was it tried to say for a nice sample of different clinical diseases, which data domains actually necessary to find the people who have the disease. And I know in the back of the room it's probably hard to read. All you're really looking for is at these Venn diagrams. This top one here is atrial fibrillation. And just to orient you to the picture, you're seeing a few different circles here. You're seeing this kind of yellowish circle is ICD-9 code, so diagnoses. Data that would be in our condition domain? Slides are up? Okay. Oh yeah, for those of you in the, actually for everybody, but particularly for those of you in the back, we've posted the slides on the Odyssey website under the tutorial page. So if you're having a hard time seeing what we've got up here, you can just pull them up on your screen. There's a PDF of them. And I'll try to explain them as best I can as well. So here what you got is atrial fibrillation. This yellow circle is diagnoses codes, records that would be in the condition domain. This blue circle represents medications, so the data that would be in our drug domain. This kind of greenish circle here is actually the data that comes from primary notes. And the intersection is basically, if you are looking for people with atrial fibrillation, how many people are identified using diagnoses alone? How many people are identified using drugs alone? How many people are identified using primary or notes alone, and how many people have the intersection or combination of those things. And so you can see if you're looking for atrial fibrillation, there's actually a good chunk of people who you're probably going to find best just looking for drugs by themselves. Some people by conditions by themselves. But if you're looking across this panel of 10 different diseases that these authors reviewed, what you notice is that the size of the circles and the amount of overlap varies considerably. You've got Alzheimer's and breast cancer and gout and HIV and multiple sclerosis and Parkinson's and rheumatoid arthritis and type 1 diabetes and type 2 diabetes, and all of these exhibit different patterns. The one main thing that I concluded from reading this really nice work was that it's probably insufficient for us to think about defining any one disease by one data domain itself. And we probably shouldn't be thinking that we're going to develop some strategy to have a particular preference for one data domain. Instead, when we're going to define our cohorts, we're likely need to start by saying, okay, what is that clinical idea that I've got in my head? and what are all the observations that might exist across the domains that I might need to go look at to try to reconstruct that idea that's in my head. And I think it's very powerful to think about the idea that given that these diseases are so different, it means there isn't going to be a one-size-fits-all solution to how to create the phenotype, but we might still be able to have a gold standard process for defining phenotypes that could accommodate all of these different situations. And what Chris will walk through as you get to play with Atlas is what we think is a tool that fully accommodates defining all of these diseases in all of these different ways, represented by one common framework. It's also important to highlight, so this is another paper that was published by Mark Roseman looking at heart failure. And what they did was they said, well, okay, there's lots of different clinical elements that could be used to define heart failure, including diagnosis codes and lab values and whatever. But how do I find all the people who have a disease, given that there's lots of different data elements that can be considered? For example, using these Venn diagrams as an example is, do you want the intersection, the people who have all the elements? Or do you want the union, the people who have any of the elements? And that's actually a really important consideration. If I go find the people who have everything, I'm probably going to be left with a very, very small set of people. Now, it might be that that very small set of people, I'm really, really confident actually have the disease because they've got every marker under the sun to find it. However, if I'm trying to estimate the incidence of that disease, that might be way too specific for what I have in mind. On the contrast, if I take the union of all of these items and just say, as long as you have one of any of these elements anywhere, well, I probably am going to cover the space. I'll probably have a highly sensitive definition, but how confident are we about a person if they have heart failure, if they only have one single diagnosis code and no other corroborating evidence? This gets to the idea that your clinical idea in your head and the algorithm that you generate, we need to evaluate that algorithm to actually answer the question, how well does the algorithm do at reconstructing that idea that we've got in our head? And that's why we're going to talk this afternoon about evaluation is a necessary component of creating cohorts. It is not good enough to just create a cohort and say, heart failure is defined by people who have ICD-9 428 star. We have to be able to add to that, here's what the consequence of that means in terms of the percentage of people that I think I'm recovering and the percentage of people that I'm finding that actually don't have the disease that I had in my mind. And so within the Odyssey community, I think one thing that we are starting to converge on is the idea that when we talk about phenotyping, phenotyping isn't just creating the cohorts, it's also evaluating the cohorts to make sure we know how they perform.
Question?
Yeah.
So, from a claims perspective, there are a number of other tools for building cohorts that have been out there, such as the CMS chronic condition data warehouse definitions or the HCC's classification conditions.
Yep.
Has the Odyssey team already done compare and contrast analyses of the predictive power and applicability of cohort definitions through OMA compared to some of those other standards?
Yeah, it's a good question. So just to repeat that, the comment was, and if I correct me if I missed it, there's been some efforts, particularly in like US claims data, to create cohort definitions that are being used, such as the chronic condition warehouse, and there are established value sets that exist that are used to represent ideas. There is work in the community that is being done to say, can we just implement those value sets in the Odyssey tool set, to which that answer is provably yes. There's nothing that any of those definitions, if you want to use them against your OMA common data model, there's a direct one-to-one translation. In fact, even what you'll see, we'll use the phrase concept set instead of value set for very important deliberate reasons. But in fact, if you've got one of those and you want to use it, you can use it against your OMA common data model, and you can build it using the Odyssey tools. No questions asked about that. We've been able to prove that repeatedly. The broader question, though, is, are those definitions inherently correct? So sure, we can implement them, but are they good? And I think that there's actually a huge opportunity for a lot more research to be done in evaluating those. What we're going to talk about today isn't actually necessarily like for any given disease. I'm not going to tell you the path that's going to get you to a single phenotype definition. I'm going to tell you what is the process to create a phenotype definition and evaluate it. And actually, as it relates to evaluation, one of the powerful things about doing evaluation is to compare alternative phenotypes. So if you're thinking, well, chronic condition warehouse already has a definition of diabetes, I guess I'll just use that. What you could consider is, well, how else could I define that? And then let's evaluate both of those two cohort alternatives against each other and measure their performance. And then you can make an informed choice about which one meets your needs based on their operating characteristics. Yeah.
I happen to know that CCW actually has a definition from 15 years ago or so. All are old and some of them do not match anymore the clinical criteria. So I do know from our CMS colleagues that actually they meant to review. So what they were, Ryan was saying about you changing or counting them, I think would be beneficial actually if you have other ideas. Because as we all know, medical research changed, clinical criteria have changed. So those definitions are not anymore.
Yeah. Yeah, that's a great point. Yeah, I mean, particularly in the US, we are still feeling the pain right now of having made this transition from ICD-9 to ICD-10 back in October 2015, and the vast majority of our research in defining diseases is still ICD-9 based, and we have no idea whether any of that stuff actually applies in our new world of ICD-10. You know, the rest of the world has been on ICD-10 for a while, so actually maybe we could learn from them instead of just continuing to plow forth in blissful ignorance. Okay, so here is a definition that I'm going to use for the rest of the day that's going to actually be quite important. Cohort is defined as a set of persons who satisfy one or more inclusion criteria for a duration of time. I'm going to repeat that again. A cohort is a set of persons who satisfy one or more inclusion criteria for a duration of time. What this means, and there's some consequences to this definition, and we're very precise in this particular language, and everything you're going to see is predicated on this definition. So if you don't like it or you want to challenge it, this is going to be your time. Here's some consequences to this. One person can belong to multiple cohorts, because as long as a person satisfies the criteria for any given cohort, they can belong to as many cohorts they want. That's super important because if we want to actually find the intersection between the people with dabigatran and the people with stroke, they need to be in both cohorts. And in fact, this idea of finding intersections is going to be fundamental to pretty much every analysis we do. Consequence number 2, one person may belong to the same cohort at multiple different time periods. So I could be a person who, if my cohort is people on dabigatran, I could be on dabigatran for a while. I could then stop and leave the cohort. Sometime later, I could start it again and join the cohort again. So there is no rule that you are only in a cohort once. You could actually belong to a cohort as many times as you want. However, the third point is that one person may not belong to the same cohort multiple times during the same period of time. Okay? You are either in a cohort or you're not in a cohort at any moment in time. And that's important for evaluation because we're going to be able to actually ask the question, at a given moment in time, are you in or are you out? And so you can think of a timeline for a person. At every moment in that timeline, you could actually ask, are you in or you're out? Are you in or you're out? Are you in or you're out? And every span of time that you're in, that is when you belong to the cohort. And every span of time when you're out, that represents the time that you're not in the cohort. One cohort may have 0 or more members. You can define a completely precise and perfectly valid cohort definition and execute it against a database and get nobody back. And it's not because the cohort definition is wrong. It's because you don't necessarily have the observations in your data to substantiate the criteria. During one of our exercises, in fact, you may get to experience this on one of our databases, and hopefully you'll gain some insights from seeing what happens in that particular consequence. And then the last one is just a Patrick pet peeve, but I'm going to say it anyway. A code set is not a cohort. I read too many papers that just say, I define my cohort as 250 star. A list of ICD-9 codes is not a cohort. Why? Because the cohort actually requires criteria that has some sort of logic to define dates. And a list of codes, I could take a list of codes and turn it into logic, like saying, I will say that I enter the cohort the first time I observe any of the following set of codes, and that I will leave the cohort the last time I observe any of those codes. But to provide me a list of codes does not provide me the ability to actually address the cohort definition, which is, what is that duration of time? This is a point of angst for some people in the OHDSI community, because many people will say, I don't care about the duration of time for my cohort. Like, for example, if you're doing a GWAS research and you're just trying to actually correlate someone's genetics with some disease state that they have in the future, you don't need to know when they necessarily had the disease, because you're correlating the genetic markers that are at birth that presumably preceded the development of the disease. So therefore, you don't need this duration of time. Many of our analyses will not use this duration of time as part of the analysis, or not both the start and the end. But just because a specific type of analysis doesn't need that information, doesn't mean that some other types of analysis might require that information. So if you're going to define ischemic stroke, why not define ischemic stroke as the period of time that a person has had an ischemic stroke? If we can create that reusable Lego brick, we can actually take advantage of applying it to many different circumstances. So, to dissect the anatomy of a cohort definition, I'm going to draw this timeline of a person. In the OMOP common data, so actually just in the world in general, but I'll use OMOP CDM jargon here for a second. In the OMOP common data model, we have the notion of an observation period. That's the span of time that you expect to observe clinical observations for a given individual. So you can think of the fact that a person exists from birth to grave, but as it relates to the perspective of what a database sees, there's an observation period start when you start observing data for a given individual, all the way to the observation period end, which is when you stop observing data for the individual. And what we're basically doing is, for any cohort definition, is we're asking the question, during this time horizon, when are the moments in time that you actually qualify for this cohort, and when are the times that you don't? And to do that, there's a building blocks, and Chris is going to walk through actually how to implement these in Atlas. But there's a way that we've realized that we think is a good way to structure how to think through this problem. The first is not just to scan through those moments in time literally every day, but instead to say, there's got to be something, some moment that we are calling an initial event, which defines how you enter a cohort. So if I'm defining my cohort as people who initiate dabigatran, it's probably the moment I first got my dabigatran. If I'm defining it as people who got ischemic stroke, it's probably the time that I first observed the ischemic stroke. But there's some event, something that's observed that happens at a moment in time, and we're going to use that as an anchor to identify all the people, or all of the moments that people have had where they might possibly qualify to enter the cohort. Once we've defined that initial event, we can apply inclusion criteria that use that anchoring event as a moment in time, so that we can define temporal logic to look for other observations that would either qualify someone or disqualify someone from still remaining in our cohort. So for example, we might have inclusion criteria that says, people who initiate dabigatran, they have to have had prior diagnosis of atrial fibrillation. When I say with prior atrial fibrillation, prior is where the temporal logic got fed in. I've got an anchoring event, which is when I start my dabigatran, but I need to be able to say, I need to observe a diagnosis of atrial fibrillation some period of time prior to when I started the treatment. And so we could have an inclusion criteria that says, I've got to observe at least one atrial fibrillation diagnosis in some unit of time preceding that initial event. So we can define inclusion criteria to look for things that did happen, and require that they have to be observed to happen in order for someone to remain in our cohort. You'll notice that I keep using this word inclusion criteria, and I've been trying to avoid a different word, which is exclusion criteria. And that's actually very, very deliberate and intentional, and something we've been trying to focus on within the OHDSI community. Because a second pet peeve that I've got, and Chanwan, I've had to deal with this quite a lot, is whenever people write inclusion criteria and exclusion criteria, somehow their mind goes haywire and they start writing exclusion criteria with double and triple negatives. So you're excluded if you don't not have this other condition that didn't previously not happen. And we observe this time and time again, that when we define inclusion criteria, people understand what that means. You are included if you observe something. But if I define an exclusion criteria, I have to be clear, is it I'm excluded because I observed something, or am I included because I didn't observe something? And time again, we've seen people talk past each other and get this confused. So what we've done in OHDSI is we've abolished the term exclusion criteria. We define everything as an inclusion criteria to avoid the double and triple negatives. But what that does is that requires us to have precision about what is the actual idea of an exclusion criteria. Usually it's, if you observe something, I don't want you to belong to my population. Well, how do we define that as an inclusion criteria? We say, I'm going to look prior to my index event, and I'm going to make sure that at least exactly 0 occurrences of something have happened. So for example, with dabigatran, we are going to exclude people who have had mitral valve stenosis. Another way to define that as an inclusion criteria would be you have 0 occurrences, 0 observations of mitral valve stenosis. By defining everything as an inclusion event, we are basically going to say you are included if you do observe some things, and you are included if you don't observe some things. But you'll be able to define that based on how many times you observed clinical elements throughout your data set. So we've defined an initial event, that's your anchor, to basically determine which moments in time do people possibly qualify. We've defined inclusion criteria, which are subsetting those individuals down to those that still remain. And so now if I think about my definition, it's a cohort is a set of people who satisfy a criteria for a duration of time. I've now set my entry point. I've defined my criteria. I also need to define a cohort exit. What is my strategy for leaving the cohort? So if I enter in because I've initiated dabigatran, when do I leave? I could leave because I stopped taking the drug. I could leave because I've had some censoring event, like I died. I could leave because I've left the database. Whatever the reason is, we would like to have a definition that allows us to know when someone enters the cohort and when they leave the cohort. This regularly comes up as people saying, I don't really care about this cohort exit thing. It just kind of seems like an unnecessary step. But it turns out time and time again, we find that there are situations for exposures and there are situations for acute diseases where the idea that someone could enter a cohort and exit a cohort and enter back in is actually profoundly important. It enables us to do research like self-controlled case series designs. It allows us to study recurrence of disease. It allows us for looking for seasonal patterns in utilization. And so while your one particular use case might not care about this, if you can embrace this idea that you are building the Lego bricks that are going to serve as the input for every subsequent analysis, not just for yourself, but for all of your colleagues in your own institution. And not just for your institution, but for everybody in the OHDSI community, then if we can all build all the Lego bricks together, we can have the cohorts that everybody can reuse to do their own research. So the questions that you're going to be answering when defining a cohort are the following 3. What initial events define cohort entry? What inclusion criteria are applied to the initial events? And what defines a cohort's exit strategy, a person's cohort exit? you should be asking yourself those 3 questions whenever you're defining a cohort. And actually, Chris, you want to pass out the worksheet? Yeah, you guys can pass those out. We're going to hand out here a worksheet, and all the worksheet says is these 3 questions. It's not very profound. But in fact, what we've found time and time again, and actually Peter can attest with our prediction classes, this happens all the time, is when we get ourselves caught up in doing analyses wrong, it's almost always because we just didn't answer these 3 questions correctly. It's never the statistics, it's never our features, it's never anything, it's not our code, and we always go to those places and try to figure it out. It's usually because we answered one of these 3 questions wrong. Okay, so you're going to get a worksheet that just actually shows you to think about this. Well, while you're receiving that, I'll point out that these 3 questions, where they're kind of very basic, they're profound in terms of how you can think about doing research. And specifically and deliberately, Chris and Kong are going to show you 2 different use cases for cohorts that we think are quite important. When Chris is going to show you a cohort, he's going to take the perspective of doing observational research. What if we wanted to replicate the Graham study, where they were actually using claims data and they were defining cohorts of new users of warfarin, new users of dabigatran? How would you create a cohort for that particular population? In that case, we are, and we'll go through an exercise here in just a second, we would think about our cohort entry as the time that they initiated treatment, because that was the definition of our observational research cohort. And we would apply a series of inclusion criteria, and then we'd probably exit at the time that someone stopped treatment. So observational research, like anytime you want to do population level effect estimation or patient level prediction in your observational data, this index data is going to be super important, and usually it's going to be the moment that something was initiated, and that makes perfectly good sense. But Kong's going to show you a different use case, which is equally valuable and equally important, and this is actually the clinical research use case. Because you see, that Graham paper that I showed you there, that Graham paper was actually an observational study, but it was actually in response to the fact that a clinical trial had been conducted. And in that clinical trial, the question of whether dabigatran was better or worse for risk of bleeding versus warfarin was evaluated prospectively in a randomized experiment. And in a randomized experiment, what we're trying to do is we're trying to recruit patients into our study. And so what we're actually interested in there is not people who initiated warfarin or dabigatran, because that's the item that we're randomizing to. Instead, when we're doing clinical research, our entry criteria is that moment we're considering enrolling someone into our trial. It's before treatment, because treatment is the thing that's going to happen after we determine they qualify. So there, what we'd actually be talking about as our index event would be patients with atrial fibrillation. Because we've got a moment that they're being observed with atrial fibrillation. That is the indication that we are trying to treat. That is the population that we're going to consider randomizing people to these alternative treatments. And it's that moment in time when they're observed with having atrial fibrillation that we might want to apply the inclusion criteria to determine, do they qualify for the study? And so what Kong is going to show you in his use case of clinical research is, imagine your job, and actually I'll be interested in knowing if this is anybody's job in the room. Imagine your job isn't to do observational research, but your job is to facilitate clinical research, to help find patients who might qualify for entering into a study, to conduct clinical trial feasibility, to actually evaluate, are these inclusion criteria that we're designing our study, do they actually make sense for the population that we're targeting? So I'm just curious, a show of hands, how many people in the room here, their primary work is actually to do clinical trial feasibility or clinical research? Show of hands. We got like five folks. What's that? 30% of your time. So, okay, so how many of you have some of your time supporting clinical research? Okay, another like half a hand. So, okay. So some of you are interested in the clinical research use case, and you're going to get to see that the tools that we're developing are explicitly designed to support that use case. And the tools are also there to explicitly support the design of observational research cohorts. But the most important part about it, like what changes it, and in fact, we're going to go through the RELY trial to show you, to try to make this point very clear. What changes it is the answers to these three questions. We're going to actually have the same exact criteria, but the difference between am I finding people who I could randomize to a treatment versus am I finding people who have been treated, that's what switches the cohort and defines our population differently. Okay. So a couple other points about this definition. So when I asked the question, what initial events define cohort entry? So the events are those time-stamped observations in the data. So that's any of our building block data domains. The event index date is going to be that event, whenever the event happens, that would be when you're saying is your cohort entry date that you're going to be able to use. And an initial event is going to be defined by some domain, usually some sort of concept set, and any other domain-specific attributes that we're going to need, and we'll show you some examples of that. What's important about this, though, is this is predicated on the idea that you're going to anchor a person on a moment in time when something is observed. One of the big challenges that we see in a lot of pharmacoepidemiology research right now is the notion that people are trying to compare people who are exposed to a product to people who are non-users. And there's a raft of papers that are being published that are people that are publishing papers that do this, and then people publishing papers criticizing people that do this. And a lot of people are talking about the statistics and how do you make balancing and all that kind of thing. But actually, I'll submit to you that the reason there's a problem with this pharmacoepidemiology design has to do with the answer to this question. Because if I want to create a cohort of non-users, what's my initial event? What is the moment in time that I am a non-user? Every day, I'm a non-user. If I never took a drug, then every day I qualify as a non-user. And that ambiguity is actually what causes the methodologic flaws that are persistent in a lot of pharmacoepidemiology studies that attempt to use a non-user comparator group. It's because they can't actually define an index date for that comparator group. And if I don't have an index date, I can't make a comparison with another cohort that does have an index date. And if I make up an index date, since it's every possible day, I guess I'll just pick one at random. Well, guess what happens when you pick something at random? It doesn't look as similar as people who actually, on a moment in time, went to a pharmacy and picked up a pill. Because it turns out going to a pharmacy and having an engagement in the healthcare system is a very different kind of behavior than a random day in your life. And in fact, we can show through fancy statistics that those are profoundly different. So different that in fact, you are hopelessly biased if you try to make that comparison. And we've published several papers to show that. And a lot of people think about it as like, oh, well, that's a problem in the epidemiologic design. And I'll actually submit, no. It's a problem in the cohort definition. As long as you can create a cohort definition that has a well-defined initial entry event, you've got a moment in the sand that you can draw. And once you've got that moment, then we can get onto the methodologic issues of whether two groups are meaningfully comparable. Then we can answer the prediction question of what happens after that moment in time. But if you can't give me the moment in time that we're actually trying to draw an inference, then the rest of it's hopeless. All right. So inclusion criteria, let me build those up. So inclusion criteria. So the qualifying event is going to be defined as all people who have an initial event and satisfy all qualifying inclusion criteria. And what we mean by that is you got to pick that initial entry event first because very often, pretty much always, you're probably going to be defining criteria that are predicated on knowing what that initial entry index event is. Like most criteria, we say something like, do not include someone if they had a disease in the past. And in the past of what? You have to have a moment to look past or future or whatever it would be. But we are on this notion of time. The initial entry event gives you that index, and then your inclusion criteria can be based on that moment in time. One thing that I'll highlight about this is that depending on the type of analysis you're doing, will define, let me rephrase it. There are certain types of analyses that you will perform for which whether or not you're allowed to use data after an index date will potentially influence the validity of your study. So for example, if we are doing prediction studies, as Peter has on one of his first slides, predictions hard, particularly about the future. You don't get to use what happens in the future to predict the future. Otherwise, you're cheating. And so it's very, very important that if we define the moment in time that we're going to produce a prediction, that we only get to use information that happens prior to that date to predict the future. Sometimes we'll define cohorts where we need to look into the future to satisfy our criteria. For example, we might say, let me think of one that would be a good example. Sometimes we might say that a person is defined as having a disease if they've had a sequence of elevated lab tests, for example. And if I take a liver function test, I want to make sure that someone's actually got liver failure. So I'm looking for ALTs and ASTs and bilirubins that are increased for some duration of time. When we define the index date, we might say that the index date is the first time that you had elevated labs, but that your inclusion criteria will look in the forward to say, did we see other elevated labs in the future to qualify you? So these inclusion and criteria are relative to time, but they could be before or after. But you have to think very critically about how you're going to use your analysis to decide whether it's appropriate to use data that's in the future for any analysis that you might perform. All right, and then the last component here is the cohort exit. So the cohort exit signifies when a person no longer qualifies for cohort membership. I will say that a lot of times this is actually just challenging to define simply because we don't know or we don't observe the thing that would actually make someone no longer qualified. I don't know about you, but about a month ago, I got ill and went to the emergency room, and I was in there and they collected an awful lot of data about me, and then they sent me home. I didn't go back to tell them that I got better. I just disappeared. And so when did I leave that cohort of being extremely ill? A couple days after I left the hospital. What information does that hospital have about me? Absolutely nothing. They just know that I complained an awful lot and they thought that I wanted some opioids. I didn't. The importance here is that if you can observe when someone exits, it's good to have that information. Sometimes you won't. I'll give you examples where we often have a lot of ambiguity around this. Chronic diseases. Many people would assert that, for certain diseases, once you have a disease, you're kind of unfortunately stuck with that disease forever. If that's the case, then you might not have any observations that tell you that someone doesn't have a disease. We might need to infer that they just exit the disease state when they exit the database. And for many chronic diseases, that might be the best we can do. Going back to our diabetes example, for example, it is certainly possible with appropriate diet and exercise management that you could get to the point that you're adequately controlled without anti-diabetic treatment. But oftentimes we can't observe that. It's quite reasonable that people oftentimes would say once someone gets to the state of diabetes, we may just consider that they are a diabetic for the foreseeable future, and that probably will be right for most of the people most of the time. We can define an exit, though, to be some fixed period of time. So we could say, for example, my cohort is people who have the flu. We know that a flu lasts, if you actually did get influenza, it's probably going to last for 7 to 10 days, and then you're probably done. And most people who get the flu, they don't go back to the doctor to say, I'm good now. So what you could do is just say you entered the cohort when you went and had your health encounter and complained of the flu, and you leave the cohort 10 days later. And you could just have that be a fixed unit of time, and that's perfectly fine, and you have to think about the consequences of it. You could think about it being like the last event in some sequence. So for example, treatments. For dabigatran, we might say you started the cohort when you started your dabigatran, and you'll stay in the cohort so long as you keep taking dabigatran. And once you stop taking dabigatran, that'll be the moment that you stop belonging to that cohort. You could also have censoring events. So you could actually say, what else would I have to observe so that I would no longer consider myself qualified for this cohort? For example, if we're studying dabigatran and we're particularly interested in dabigatran monotherapy, well, I might censor the cohort if I see that warfarin is used. Because if we see that switching behavior to another treatment, maybe I want to say, hey, I'm out of this cohort. I am no longer a dabigatran monotherapy. So when thinking about a cohort exit strategy, you just want to think about what collection of things would be observed or inferred that would have you leave your cohort. Okay. So just in terms of jargon that you might hear that we sometimes use, particularly as you start to play with Atlas, we're talking about domains, and the data domains that we're really talking about here are those building blocks of the data that's in the common data model. So conditions, drugs, procedures, measurements. And so we'll be asking you, like, what domain of information are you going to be looking for to use to define your cohort? We're going to be creating concept sets. So concept sets are sets of concepts that you can actually, the actual items that you can observe. For purposes of what we're going to be teaching you on, we've actually prepared and created the concept sets. Concept sets is a class in and of itself, and in fact, it's happening 2 rooms down. If you are interested in learning how to navigate the standardized vocabulary and to construct concept sets to define clinical entities, encourage you to go take that class. You're going to get to just take advantage of concept sets that have been created for our purposes. Some of the domains have domain-specific attributes that you can make use of. And so we'll use a couple of these as examples. So for example, a visit. Something that's unique to a visit is the notion of length of stay. And that only applies to a visit. It doesn't apply to any other data domain. But you might say, like, I'm looking for a visit who I'm in the hospital for at least 7 days. Or a measurement has something like a value and a normal range and a unit. And those things only apply to the domain of measurements. And so whenever we define a criteria, we can actually say, I'm looking for the absence or presence of some entity in some domain. Those concepts that I'm going to look for would belong to my concept set, but I might also further qualify my criteria based on any of these domain-specific attributes. And then we're going to define temporal logic. So when I say temporal logic, think of it as what is the period of time relative to that index anchoring event that we're going to be using to actually define a particular criteria. And so all inclusion criteria are going to have some temporal component to it in order to make sure that you're examining the data correctly. Okay. So I want to just talk you through very briefly, and then Chris is going to walk you through how to use Atlas to do this. I'm going to go back to the Graham paper here real quick. I'm going to highlight the text that is used to describe what I'll call a cohort in the publication, so that you can think about that worksheet you have in front of you. How would you define the initial event, the inclusion criteria, and the cohort exit? And I'm going to do this with 2 examples real quickly. The first is in the Graham paper. Remember, they're studying these dabigatran and warfarin for a variety of outcomes. Whoops. That's all right. There you go. The outcome that I'm going to look at here, so they say the primary outcomes were ischemic stroke, major bleeding, with a focus on intracranial and gastrointestinal bleeding, and acute myocardial infarction. Secondary outcomes were hospitalized bleeding. And this is actually probably my favorite part. We decide to spell out the words. The International Classification of Diseases 9th Revision Clinical Modification Codes were used to define the outcomes. So we use 2 lines of a sentence to write those words, but we don't actually provide the codes. We just say that there are codes. You got to go get to this supplemental material, and then you get this thing, which says something like ischemic stroke 433.x1, 434.x, except subcode x0 and 436. It's in the first position, and it's an inpatient-only code. So this is what the paper provides. And actually, again, we use this paper as kind of a good example of best case of what's going on in the community at large. But my question for you is, if we are creating a cohort for ischemic stroke, and this is our definition of what we're trying to do. What's our initial event for finding strokes in this database? So the first time we observe one of these codes, so we've got this list of codes, so I'm going to look in the data and I'm going to just find the first date that one of these codes happens. So that could be our cohort entry, okay? And specifically this qualifies it as saying it has to be in the first position, which in claims jargon is the primary position of the claims record, and that it has to happen in an inpatient claim. So what if someone had one of these diagnosis codes in the second position, but it occurred the day before the code that was in the first position? Would that outcome qualify? I hear why not? I see no. I see a yes. It's unclear. It's unclear because what we're provided is a list of codes, not the logic that says, is it the first occurrence of any of these and that first occurrence must satisfy those criteria? Or is it the first occurrence of that combination of rules and it doesn't matter whether you've seen this before? Can people have multiple ischemic strokes clinically? Are we? Yes. So given that, how many strokes can satisfy this criteria? The first one? So actually, this paragraph doesn't actually provide the full context. So I'll just tell you. So what's the interesting thing is that this definition takes that. We started with the question like, why don't we just take the cohort and look forward from that moment in time and just say that the people have the event, yes, no. If you do that, you're not actually looking for their first stroke. You're looking for the first stroke after they started the treatment, which might not be the first stroke. It might be the second stroke, except that you want to make sure that it is the first stroke, except that you don't have an inclusion criteria to say you didn't have a prior stroke. And so we actually, the reason for coming up with this definition that can be useful is we may want to create a cohort which is first ever time that people created an ischemic stroke, or had an ischemic stroke. If we create that cohort definition, then every person could only possibly qualify once. And that one event may occur before their dabigatran or after their dabigatran or not to dabigatran at all. But you would actually have the events and when they happened. You'd have the temporal logic to know the date that they qualified and the date that they would leave. Right? So getting the initial entry event is super hard if what you just get is a set of codes. You can make some implicit assumptions that like, oh, I think this probably is this first occurrence, and more times than not it might be. But in the real data that we often are all working with, there are lots of messy edge cases that you've got to be able to handle, and you want to be able to provide explicit logic for that. Now, in the interest of time, I'm not going to make you read this blob of text, other than to say there is a blob of text in this paper that describes all of the criteria that qualifies the exposure cohorts. And if you look through that blob of text, you'll see like there's lots of complex words and lots of commas because it's a big long run-on sentence. One of the things that we've discovered in creating cohort definitions is the need for precision in the describing exactly who and how everything qualifies. And whereas I showed you the outcome gave us the ICD-9 code list to find the stroke, here there's a variety of different clinical terms that are defined here, but I don't know what codes define them. I don't know what temporal logic is applied to apply them. I don't know what, I know what my initial entry event is, dabigatran or warfarin at the top. But there's a variety of different decisions that you all have to make when creating cohort definitions. And one of the things that Chris will show you as you start to play with Atlas is that we're not trying only to provide you software that helps you point and click through defining a cohort, but we're trying to also help you have a completely reproducible and fully transparent process to describe and define that cohort so that other people can know what you've done. And so, for example, having your cohort definition being written in human language words that fully specify everything that needs to be described so that you don't just end up with a paragraph that's really hard to decipher, but rather that you have something that if I have the human words, I can add a one-to-one mapping to the code that needs to run it. And similarly, if I have the code, I can write human language words that actually describe it. What we've built in Atlas, what Chris has built in Atlas, is actually very impressive from the perspective that by having a cohort definition logic available, we can use that logic as researchers to define the idea that we want to do, and also use that same logic to actually communicate what we have done. By writing protocols and writing publications, we can make all of that fully transparent. So last thing that I'll highlight, so when defining an initial event, what you need to do is make sure you define that based on some of the existence of some observation in the data. What you don't want to do is define that by the absence of an observation, because you don't really know when something doesn't happen, because it doesn't happen all the time. We see lots of epi studies that are actually trying to define things as like birth year cohorts. And the challenge there is you just need to think very carefully about what does it actually mean to have an index date. You want a birth year cohort, is it the birthday? Is it January 1st? And if it's January 1st, that's probably a random day for most people in their lives. And so you want to think about the consequences of that. As it relates to inclusion criteria, the do's, make sure you specify all your criteria as inclusion criteria. Try to avoid the confusion of talking about inclusions and exclusions. So otherwise, you'll probably get yourself tied in knots, as we'll see some examples of. Try to use information that's on or before the index date. Particularly for a lot of your analysis, use the analogy of thinking about a randomized trial. How does a person qualify for a study? You only get to know about the information about a person up to that moment that they're being screened. You don't get to know about the future. And so you should think about that as a design principle that you follow. Do not assume temporal logic. Always explicitly define the time windows that you're going to use. And that's important there. And then cohort exit. What I want you to do is always define a cohort exit criteria. Even if you don't plan to use it, go ahead and define it. Because whether you're going to use it or not, someone else might. And also having the clarity of thought about what gets someone in and out of a cohort will actually help you with your clinical description. Don't confuse censoring for analytic purposes with censoring for a cohort definition. Many times in analyses, we might do something like we'll do a time to event analysis for causal inference, in which case we'll only follow a person until they've had the event. The cohort definition doesn't need to handle that. Our cohorts themselves are independent items. Our analysis will handle the fact that there's going to be censoring due to the particular statistics. And so what you need to do for your cohorts is just create the people who qualify for that clinical idea that's in your head and build all those building blocks. And then you're going to be able to take those building blocks and perform all the other analysis you want. And it's the analysis job to sort out these other details. Okay. With that, I'm going to transition over to Chris. Chris is going to walk you through a demo of using Atlas, taking the clinical trial that was actually defined, that was the preceding trial to that Graham paper, is the RELY trial, and he'll show you the details. Throughout now and the rest of the day, we're actually going to be using Atlas, and you all have access to Atlas. Thanks to the generous contributions of James Wiggins and Amazon Web Services, we've actually been able to spin up an Atlas instance that is only for the purposes of this tutorial class. So basically it's here for you guys for the next couple days for us to go through these trainings, and then it's going to disappear. But that link is here. It's cohort.odysseytutorials.amazingaWSdemos.com. When you go to that URL, you are just going to be brought directly into Atlas. We're deliberately going to go through 2 demos first. Chris is going to do a walkthrough of how to actually use Atlas to create a cohort definition. And then Kong is going to do a demo to show you how to use criteria to query. I would, it's up to you how you want to handle this, but you might, depending on how you like to learn, you might find it useful to just go to this website and follow along, watch Chris, or you could just watch the screen and watch him as he goes through each of the steps. And similarly with Kong. Just to be clear though, after this demo, you're gonna just see how it's done. You all are gonna get a couple hours to actually do it yourself, and there's a whole bunch of us that'll be walking around to help you develop this skill. Any questions for me? Yep. Oh, that's just a yawn. Okay.
So I just got curious in this idea of the major issues in pharmacoepidemiology, creating a non-user cohort. I know you mentioned when you choose the day randomly for those competitors, that's one of the main. Can you expand a little bit more on that?
Sure. So, and actually, if you take the population level effect estimation class, we'll dive into this even more. But the basic issue is that generally, if you want to perform some comparison, what you're trying to do is do a counterfactual analysis. It's people who made this choice, and you kind of like in an ideal world that they would make an alternative choice. And so that really means that you have to be at a moment in time where a decision was made. And it's super hard to think about what a decision is made when there isn't something that's actually taking place. So non-use, I mean, every moment, now, and now, and now, I'm making the decision not to take a drug, but it's kind of an arbitrary fake thing. Whereas when I go to a pharmacy and pick up a prescription, I've made the choice, the declaration that I'm going to make that choice. And so comparing 2 alternative choices between 2 treatments makes logical sense because I go to the pharmacy, I initiate an encounter with the healthcare system, I just either grab the blue pill or the red pill. That makes logical sense for a comparison. When I want to make a comparison to not taking a pill, it's just hard in our data to model that moment that I go to the pharmacy, but instead of grabbing the blue pill, I grab nothing. Because many of us don't go to the pharmacy when we grab nothing, unless we're trying to get a Snicker bar or something like that. So that challenge is really a fundamental challenge for all of epidemiology. And very often you'll see in the literature, it's described as an epidemiologic study design problem. And it can be couched that way, but my assertion to you is if you think of it as a cohort definition problem, it actually becomes a little bit easier to realize what the real problem is. If you can come up with a good cohort, then you can do a good analysis using good cohorts. And if you're struggling to come up with a cohort, no fancy statistics are going to solve that problem for you. Yep.
How do you define a placebo?
I have a mic.
Yeah. So that's exactly the same thing there. Is that placebo or like non-use? Yeah. So in our observational data, we typically don't have placebo. Because there isn't, at least in the US, we seem to frown on giving people sugar pills for no good reason. But it's a challenge is, can we in some way model that behavior as if someone was getting a placebo? And so sometimes in studies, people will do interesting proxies. Like for example, you went to a pharmacy, but you picked up a different drug for a different purpose. So that's a moment that you at least went to the pharmacy, but you didn't get a pill for the indication of interest. But all of these, this is an active area of research. I would certainly say that there is no definitive conclusion, but what is a shared recognition is non-user studies get you into lots of problems often. And the primary reason for that is because defining the cohort and when you belong to the non-cohort is just non-trivial. And so as we go through these examples, actually it's be good for you to be thinking about the importance and the value of nailing that initial entry event. And you're going to see a couple examples of that initial entry event and why that's so important to get in there. All right, good job. So the question from Chanwa is cohort definition reuse. Like, so what do we need to do, and what are the mating needs? So actually, I'm going to slightly table it because in the afternoon session, I'm going to talk at length about this. But the short answer is what Chris and Kong are going to show you all is how you can actually create a cohort definition. And Chris will show you that cohort definition is now a completely reusable object. It's a piece of code that anyone in the world can take and make use of and reuse. So I think we've actually solved the technical problem of enabling phenotype definition reuse. The challenge that still is to overcome is the social one, which is how do you make you guys share with each other? Share in an appropriate way that everybody feels comfortable. And I think we're making some really good progress as a community on that, but there's still a lot more to be done. And the phenotype work group is actually specifically trying to think about technical solutions to that non-technical problem. Namely, can we create a shared trusted library where people can offer up definitions and that people can grab because they know that they've been well curated by a phenotype librarian? And that's what we'll talk about at length this afternoon.
Okay, so what we're going to start with is we're just going to talk about the clinicaltrials.gov site about where this protocol and trial was defined. So this is the randomized evaluation of long-term anticoagulant therapy with DABI. Is everybody familiar with clinicaltrials.gov? They've seen it? I'm not going to go into a history of this site, but we'll scroll down to what the study design is. They have a nice, they're saying it's a comparative study. The two arms are going to be dabigatran and warfarin. We have their purpose is to check the efficacy and safety for various outcomes. Going to jump to the criteria for the study. So as you recall, Patrick was talking about the moment in time that we're gonna find the people to enter the cohort. And if we were just trying to understand from a clinical research perspective who qualifies for the study, we would use the atrial fibrillation as the index event or the initial entry event to determine like who qualifies for this study. But what I'm going to do is I'm going to set up a cohort definition that describes one of the arms, the warfarin arm. And so my index event for my cohort definition is going to be warfarin exposure and the first warfarin exposure. Then I'm going to use the inclusion criteria for this study to be the inclusion criteria of those people first exposed to warfarin who qualify for the study. And who qualify for the study means have the inclusion-exclusion criteria satisfied. So the inclusion criteria, like the main inclusion criteria is that these patients have suffered non-valvular atrial fibrillation. They also should be moderate to high risk of stroke, and they describe what these factors are. And then they start going in, so as long as you're at risk of stroke, you've taken warfarin, and then we start talking about what these exclusion criteria are. And what I want to do while we go through these is really think about, can observational data really support all of these criteria, and how you would think about getting into, how you would define these criteria using observational data. Certainly from the inclusion criteria, it's feasible that we can define people suffering from the AFib event. We can determine an age. That's certainly something we can observe at the event. We can, all these additional risk factors equate to either maybe a lab value or another diagnosis code. So everything in the inclusion criteria seems pretty feasible. The exclusion criteria says that for the first one here, we don't want prosthetic heart valves requiring anticoagulation or any valve disease that might require surgery. This is basically saying that it's not valvular if you have these issues. So anybody who may develop a valvular problem, they should be excluded. Now remember, we also said that we want to think in terms of exclusion, like we don't want to think in terms of exclusions, we would like to describe this as an inclusion. So what we're really saying is that there is no observation of this particular observable characteristic. So we're saying include them if there is no presence. The second one is, but the first one does look reasonable. We could do that one with observational data. Severe disabling stroke within previous 6 months or any stroke within the previous 14 days. we'd have to think about a little bit about what disabling means. Maybe that means that they had a hospital visit. So we could describe it as they had a stroke and they stayed in the hospital for so many days since they were unable to leave the hospital. So maybe that's an option. And then there's an or here, or they actually had a very recent stroke. They're also out. So disabling stroke in the last 6 months, or stroke, any stroke, in 14 days. So also feasible, we could do that. Conditions associated with an increased risk of bleeding. They don't explicitly state what that is, but we could do some research and look at publications or other places that would define, like, what are these, how would we describe that? And so feasible that we could describe that in observational data, although they don't actually explicitly state what that is in this particular sentence. Contraindication to warfarin treatment, right? So if you're going to be in the cohort, we're going to give you warfarin, you cannot have a contraindication to it. They also here just give you like the idea that it's contraindications to warfarin, but they don't actually explicitly state what that is. We'd have to go to the product label and look at all the contraindications and exclude people that way. And when I say exclude, I mean they must have 0 of any of those indications. Reversible causes of AFib, so surgeries, also feasible. We could look for procedures in the common data model for these type of issues. A plan to perform a pulmonary vein ablation or surgery. Does anybody think that we have plans in our observational data? Probably not. So this is one where we probably aren't going to model this in our cohort definition because we can't get into the mind of somebody about what their intent to do is. So we won't do that one. Severe renal impairment. Okay, so they even talk about what measures we should look for, so that's cool. Active infective endocarditis. So active, what does that mean? Does that mean that they're saying recent? We can assume that's what they mean here, but it's not clear. It's a little ambiguous, but we'll say active means that it was something in the last 90 days, say. That's considered active. Active liver disease, same type of thing. Women who are pregnant or childbearing potential who refuse to use a medically acceptable form of contraception. Half of this, we could say if you're pregnant, you're out. So no pregnancy. But the notion of refusing to use contraception, that may not be captured unless we have some kind of survey data that they would state that they would never use contraception. But for this, we can go as far as to say, like, exclude people who are pregnant. Anemia or thrombocytopenia, that is just another condition or measurement, but this is a nice one because it's sort of a combination. You can either clinically be diagnosed with it, or we can find a measurement that would indicate the diagnosis. So the next ones are pretty much the same type of thing where we're looking for, I'm only glancing through here because we have limited time. Is there anything in here that we wouldn't be able to do? So number 14 here says patients considered unreliable by the investigator concerning the requirements, blah, blah. Okay, we can't make that type of judgment. All these other things, all the observable things we can use to find them unfit for purpose, but the judgment of an investigator, we can't model that, so out. And then hypersensitivity to galactose, if the warfarin used contains that, we can potentially find that in observed as well. So there are 15 rules that are exclusions plus the inclusion rule, which is actually, the inclusion rule is kind of a two-parter because actually I skipped over the whole age requirement. So the age can be an inclusion rule. The AFib is an inclusion rule. The risk factors are inclusion. And then they state and 16 exclusions, but these are going to be 15 exclusions. These will be 15 other inclusions that we want to find 0 occurrences of these observants. So like I said, I'm not going to do all of these, but the ones we will be modeling in Atlas will be the age criteria, the prior AFib, the risk, the moderate to high risk of stroke, the severe disabling stroke within 6 months or 14 days, and the no anemia or thrombocytopenia. Okay, does anybody have any questions, at least as far as how I've broken down the protocol? Does everybody agree it pretty much covered what the inclusion criteria and exclusions are? Any questions? All right. So in Atlas, we would go over to our cohort definitions and we create a new cohort. But because you don't want to watch me type in all these inclusion rules with all the language, because you want to put in the names of all your inclusion rules, I've created this empty cohort definition that it has all of these inclusion rules typed out already, so that these are the ones I said I'm going to do. But inside them, we don't want to, they're empty for now. So they just have just the text in here. So.
Because you just started at the very, very homepage of Atlas.
Sure.
What they're seeing when they go to it.
Sure. So if you go to the link I had earlier in the screen, you'll have the Atlas application open up, and eventually it'll load. So the Atlas application has a lot of functions in it. What we're focusing on here today is talking about cohort definitions. So you're able to go right into a new cohort definition by clicking Define a New Cohort from the home page. Or if you wanted to open up or review an existing cohort definition, you just navigate on the left here, click on Cohort Definitions, and that will send you to the cohort definition list. This environment has various cohort definitions there. Feel free to browse at your leisure. But to start a new cohort definition, we just click New Cohort at the top, and that will send us to an empty cohort definition template. Notice no inclusion rules, no initial events or anything like that. Okay? All right. But fast forwarding a little bit in time, I've saved myself some typing by putting these inclusion rules in here. Okay, so who can remember, I'm creating a treatment arm type of cohort on this. So we're talking about exposures. So what was the exposure that we're going to be modeling for this cohort definition? Anybody? Warfarin, right? So when we click on Add Initial Event, we're basically saying, choose a domain that you want to find the observation in. And for warfarin exposure, we're talking about a drug. So we're going to go to the drug exposure domain. And so it just starts off saying, okay, fine, the initial event will be a drug exposure of something. So now it's time to say, what is that something? Yes? Sure. In the common data model, there is a table called drug error, and the drug errors are inferred from the individual drug exposures at the ingredient level. So when you talk about the OMOP vocabulary and you talk about the individual drug exposures, they may be clinical drug forms, branded drug forms, lots of low-level drug forms. For drug error purposes, we take the individual drug exposures, roll them up to what ingredient they belong to, and then any exposure that was within 30 days of each other is considered part of the same era. And the output of combining all those drug exposures into drug errors are the periods of time where that ingredient was exposed to a person. And it's at the ingredient level. So you could be taking a drug at the drug exposure level, that's a combo, and the combo might be contributing to one of the errors for one ingredient, and the other part of the combo, other error is the ingredient, right? So there's a lot of things to kind of consider with that, but the important thing to remember is that the drug error is at the ingredient level, and it combines all the individual exposures that were at the patient level into these periods of time. And by default, we use a 30-day time window to associate, did they continue in the same era, or do we start a new era because the distance between the one exposure and the other exposure exceeded 30 days. That clear? For purposes of this cohort, it may actually make sense because we could use the drug era because the first exposure to warfarin will be the start date of an era. So we could use a drug exposure or a drug era in this particular case. But I'm going to say, I want to take drug exposures. I want to look for any drug exposure from any of the clinical forms or branded drugs of warfarin, and I want the first one. That's what I'm going to say they initiated treatment at their first exposure. So in this cohort definition, I actually also pre-imported a lot of these code lists into this cohort definition, but warfarin is not one of them. So whenever you're creating your cohort definitions and you need to start getting code lists into your cohort definition to assign to criteria, you're going to have to import it or create it or import it. And we've created all of these code lists for us. So warfarin isn't here, so I'm going to the bottom and I'm going to say I'm going to import this cohort concept set from the repository. So we're going to warfarin. Here we go. This is the warfarin that I want. Okay. So we're going to look for a drug exposure of warfarin. Just as a quick peek, warfarin just is the warfarin concept and including all of its descendants. So we don't just want warfarin, but we want the first exposure to warfarin. And once we're looking at a domain's criteria, we can start asking specific questions about that specific domain. So in drug exposure, it might be the first exposure. If this was a measurement, you might look for a value. But drug exposures don't have values, they have other things. These are the list of drug criteria that you could have for at the drug exposure domain level. And the first one that we see here is first exposure. So we can just grab that, first exposure. So at this point, we have a cohort where people will be into the cohort at the time of their first exposure. Perfect. Now, if we recall, we had some of the inclusion criteria talking about you had to like exclude people or include people when we know they don't have some type of prior observation in their data. What this continuous observation is doing is it's basically saying that at the time of their first exposure, did we have enough prior observation of this person at that time? So if a person just enters your data and immediately takes warfarin after day 2, you only have 2 prior days of data to use to determine if they qualify for this cohort. This particular piece of functionality says we don't just want anybody who took warfarin for first exposure. We want the exposure that had enough prior observation for us to do other inclusion criteria checks on that patient to make sure he really should qualify. So we're going to say here that the person had to have at least 365 days of prior observation so that we know the people that we're going to use for this study has enough history that they qualify for our criteria. Notice this wasn't something that was spelled out in the clinical trial because the clinical trial is not really observational data centric. Clinical trials like we have the person in the office and we can look at everything about them that we need to determine if they're fit. But for observational data, you kind of have to say, do we have enough data to make these observations, to make these checks? So continuous observation, we'll just say 365 days. Okay. Everybody good so far that if we just took this cohort definition, all we'd have is people any age, just their first exposure to warfarin. That's what we'd have at this point. Now, we're going to start with saying, okay, the first thing that they called for in the protocol document or the trial was they have to be age greater than 18. So here's the age greater than 18 inclusion criteria. And the type of criteria we're going to use here is a demographic criteria. Now, I'm throwing a little curveball here because that's funny. Demographic criteria isn't one of the domains we talked about. Demographic criteria is the type of criteria that you can use to kind of put some constraints on the actual event itself. So how old were they at this event? What was the time window that this event occurred in? In this particular case, or the gender, check the gender of the person at that event. So we're going to just say that the only thing we need here is an age. And we're going to say the age was greater than or equal to 18. Okay? So now, if we were to run this cohort, we'd have first exposures to warfarin, and they are 18 at the time of that exposure. Okay, so next we're going to say they had the AFib, right? So we're looking for people that had the exposure and they had this AFib event. So what we're going to do here is the AFib will come from, any guesses which domain? Anybody, real quick? Condition occurrence, right? So we're going to add a condition occurrence criteria. And notice how, unlike the top where it was just like, I just want to know what the record is, this one is saying, okay, it is a condition occurrence observation that we're looking for, but we want to count them. So how many are we looking for? It's either going to be, usually it's either at least 1 or exactly 0. And when should we find this event relative to the index, which in this case is the exposure to warfarin. So we say we want AFib. So I already loaded that cohort, that code list into this cohort definition, so I just chose it, AFib. And it's saying you had to have AFib. So we know it's not going to be sometime after the event, right? So we're going to say it's between some time period before, and we're going to say it can't be after. So we're saying that's fine. But what should we say about where should it be? Is it a recent thing? Do you think that it should be any time prior? Like they just had to have AFibs sometime? Do they specify in the protocol? No, right? So why don't we just say they had their warfarin exposure and they had AFib anytime prior to the exposure. So that's what we'll leave it with this. And if we decide later, it's got to be like recent, or more recent than that, like in the last year or in the last 6 months, we can change that. But for now, we'll just leave it open. So anytime before, up to and including the index date. Okay, and we're saying here it's an inclusion rule, so at least one. You have to have at least one AFib. All right, so we're ready to move on, I think. Does anybody have questions about this particular maneuver? Yes? Yeah, I'm sorry. It may be a combination of like a lot of activity, and I apologize if you guys are trying to follow along. But honestly, in the afternoon, you'll have more dedicated time on this, and don't really focus too much on being able to follow my clicks, but just try to keep the thought process in your mind about what I'm describing as far as time windows and counting observations, because that's the most important thing you guys are going to need to kind of follow from this little talk here. Okay. All right, so rule 3 is a little bit more complicated because we're talking about a moderate to high risk of stroke, systemic embolism, and at least one additional risk factor. Going back to the way that was actually described in the document, it was actually describing the elements of a CHAD score, where if you're greater than 75, you're automatically like you would get a 2 right off the bat if you were aged greater than 75. If you're greater than 65 with one of these other conditions, 65 is a point, and these other conditions are a second point. If you've had prior stroke, you get automatically a 2. So what we're going to do here is I'll go through and I'll pull out each element of this CHAD characteristics and tell you and show you how I would do it. So the first one is their age is greater than 74. So I'm going to add a demographic again, right? And we're going to just age greater than or equal to 74. And do you all trust me on this, or do you want me to just show you how that was kind of described here, right? They're saying the previous stroke, systemic embolism, left ventricle dysfunction, age 75 years, right? So all of these guys on a CHAD score would put you at moderate risk right there, just this alone. And then they're saying, or you could have this age 65 plus diabetes, coronary artery disease, or hypertension. So there's a little bit of like these things together and these things alone that we need to kind of think about in this cohort definition.
Why don't you grab that text and paste that where you typed the word CHAD to so they can see it?
Sure thing. Okay. All right. So, there's actually saying greater than or equal to 75. Oh, good thing I read that. All right, so the next thing we'll do is we're going to look for the ischemic stroke. That's a condition. Okay, and we'll say again, we're saying all these before and up to the day of the exposure. Okay, so that's that element right there. Systemic embolism. Oh, sorry. Oops. Sorry, did I already do the... Gotcha. I'll just do the left ventricle dysfunction here. All right. All days before, 0 days after. Or 0 days before. Let's see, and then we'll do this other one that is, so we have those 3 ones that definitely are like moderate to high risk, like right off the bat, the age, the ischemic stroke, or the ventricle dysfunction. Now we have another one that is saying you can be age 65 with 3 other things. So what we're going to do is we need to group these things into saying you're going to be age 65 plus A or B or C. So in order to do that, we're going to add this criteria group here. And we're saying that we want to do a demographic of the age. Okay, and I need another group. Okay, so what I've done here is I've said that you have to either be the age, the ischemic stroke, the left ventricle dysfunction, and the age is 65 and whatever. We're gonna change that at the end. Why don't we do it now? Remember, these are going to be exclusions, right? So we want to say that none of these things happen. So I changed this little thing to say, instead of at least like all of these, I'm just going to say, pardon? Oh, you're right. Sorry about that. Sorry. So any, basically. So any, either 1, 2, and 3 here, or, and then with this or group, the subgroup of this or is going to be, they have to be 65 and either of the 3 additional conditions. So we're adding another group, that's an or, but we have to say you have to have all of these. So you have to have both age 65 and one of these 3 conditions. So here's age 65 and any of the following 3 conditions. We know that there's 3, so I'm just going to do it real quick. Add condition. Okay, the first one was going to be diabetes. The second one was going to be coronary artery disease. And the third one was going to be hypertension. And for all these cases, we're saying all days before up to the index. Oops, excuse me. Okay, complicated, right? It took me like several minutes to go through this, but this is it. Yes? Yep. Sorry. So just real quick, if I wanted to add a criteria group, say here, it's the same place that you'd find the demographic criteria or the domain criteria, but at the very bottom, there's a group option. You click our option and that'll add it as a group. All right, so this is complicated, but it's clear. Basically, we're saying you're included if you have any of the following. You are aged greater than 75, ischemic stroke, or left ventricle dysfunction, or you have the following: age 65 with diabetes, coronary artery disease, or hypertension. All these things come together, and if you satisfy it in one way or another, then you're included in the cohort. Just making sure I didn't miss any other, like the time windows. Just want to confirm that the time windows are good. Always check and make sure that your time windows look correct. They look good. Okay. Yes, question?
Yes. In the first one, you're saying all days before and 0 days before. And after the age 75, next condition.
Right, I'm saying all days before and 0 days before, yes? Did I?
No, I'm asking you, there is difference in why I'm doing it like this. Because in this condition, you're saying all days before and 0 days before.
Yeah.
In the second group set, you're saying all days before and 0 days after.
That's true. I should make it consistent, but the way that works is if you say 0 days before or 0 days after, you're basically saying add 0 to the date, and it has to be before or after. And when you add the date, it's equivalent in saying, and I apologize for the confusion, it's equivalent to say 0 days before or 0 days after, because that 0 doesn't change the day. If you said 1 day after or 1 day before, it definitely makes sense. You're taking a day, 1 day before means you're subtracting it, 1 day after means you're adding to it. But if you say 0 days before, 0 days after, you're not changing the date. You're just staying on the same date. But that's a good point for purposes of making it consistent. Why don't we just say always just 0 days after? From all days before to 0 days after. Sounds good to me. And I apologize for that confusion. Okay, cool. Next. No severe or disabling stroke. Any other questions on that?
Could you go back to your including criteria number 3? I don't get it. Basically, we're dealing
Several different conditions, yes.
65 or 65 with a different set of conditions, right?
Correct.
It looks like, the first case, in the first box, it is highlighted with a blue box, right?
Yep.
And then if you go back and then you go down, and the second one is still highlighted with a blue box, but I don't get.
Sure thing. Yep, I can see where the confusion's come from. The blue box is just a visual cue to let you know that that type is a demographic criteria. It doesn't deal with time window, before and after, it's just demographic criteria. The green box represents a correlated criteria or criteria that has, you count, it's an observational criteria.
Then how do I know that which box is linked with which box? I mean, in this case, the first box, which is demographic, is linked with either of the two below, right?
Yes, it is all these top level ones, so there's no bounding square around this. Yes, this is top level. So you're saying with any of the following, either the age or the condition or this condition, and then you see this box starting. That box represents, now I'm going to say it's another or because it says or, but now we're kind of like, think of it as a mental parenthesis that you're going to say or, and then inside that or we have an and. We're going to say age 65 and something. So what does that age 65 and something represent? That something is yet another group. So yeah, if we want to draw that on a piece of paper there.
It's tricky.
It is tricky, absolutely. But it's precise. And so that's the difference between, something that looks overly verbose but precise and something that, you know what I meant. I meant a chat score of 2. Yes?
So you did all this and then decided that you wanted it to be age greater than 75 and one of left ventricular dysfunction or ischemic stroke. Is there a way to wrap what you've already got inside of a new group?
Yeah.
Or do you need to delete what you've got and then?
No, you can, there is a little bit of a draggy and drop. So let's say I want to add a new group up here. So that group, because I added up there, actually it's a new group down here, right? But you can say, I want to move that down. So you have this sort of like dragging thing kind of action here where you can kind of drag it down. See what I'm saying there? You can move some things down, but I'm going to leave it up where it is.
I'm going to show this in my map.
Okay, so right, exactly, Patrick wrote it out perfectly. So this outer group is an or, it's an any. So we're saying either stroke or left ventricle or the age, or, and now we inside this or thing, we're saying it's an and. Or you have age and one of these other things. One of those other things is another group that's oring together. So your age and either the diabetes or hypertension or the whatever the last one, hypertension. Okay, I know that was a rough one, but it just goes to show, like, as complicated as this looks, you can handle some pretty complicated use cases with this.
The point to reinforce here is, if going back to that sentence that's in the trial, that previous ischemic stroke, the thing that's highlighted there is a lot baked into a simple sentence like that you have to be very clear about exactly what's actually playing out there. And the tool, as Chris is walking through, can accommodate you implementing that as simple or as complex as you want to be. But the most important thing is to actually make sure that you are clear about the logic. The tool's not going to be able to fix the ambiguity in this sentence, but the tool is going to allow you to implement it however you think that sentence is representing the clinical idea.
All right, now at a risk of maybe introducing a little bit more confusion and complication, I describe this rule as simply saying you had a CHAD score of 2, because the first ones they described were 2 points, and the second ones with the age, that's a point, and then these 2 other things gives you another point. However, there is a way to get a CHADS 2 score that does not qualify you for this cohort. And does anybody see it? I'll give you 10 seconds to yeah. Otherwise, I don't want to waste too much time. But would somebody that had prior diabetes and prior hypertension be included in this study? They would not, because the rule says you have to be 65 with either diabetes or hypertension, right? So you have to be 65 plus those two conditions. If you had hypertension and diabetes, you would have a CHAD score of 2. That would give you, those two contribute. But the way this logic of how this protocol is stating it says, the only reason why you'd get in here with diabetes or hypertension is if you were also 65. That's how they're describing it here. And I just wanted to clue you in on that's how some of this logic plays out in practice. Okay, so did I confuse people, or did you all get that little subtlety there? I'm going to go with hopefully you got it. Okay, so complicated rule, moderate to high risk. Okay, severe or disabling stroke within the past 6 months, or just a stroke within the last 14 days. Perfect, this will be cool. So we know we have an or, right? We know we want to say one or the other. So we're going to say, so let's say we want the stroke, right? So we want to say 0 of this stroke that's disabling. Okay, so first of all, we want to say that it's a stroke. So let's just go with that. We know we're talking about a stroke, and kind of like a broad stroke. And we're saying, when will the stroke happen? We're going to say the stroke happened anytime prior to the warfarin exposure, as we've done all the other cases. So a stroke that happened all days before, oh, actually, I'm sorry. We were saying that this stroke had to be when?
6 months.
All right, so 183 days. Thank you. I was testing you guys. Okay, so 6 months, all right, but this is a debilitating stroke. So what we said that we could describe this as is they were in the hospital for 7 days, like at least 7 days when the stroke occurred. So how do we do that? So this is a cool feature that we'll just get into real quick. But before I do it on the UI, let me just describe in a picture what we really are trying to do here. And I'll try pretty big for the people in the back. So we have our warfarin. We have our warfarin event happening right here. And we said that we want to look back for stroke 183 days to 0 days of the warfarin. Can everybody see this okay in the back pretty well? Yeah. So this is going to be the 183 days, right? So inside here, we're saying we want to find the stroke. Let's say we found it here.
You just wrote that so small that I can't see it sitting here.
It's not important what the number is. But a big S, right? We want to find this stroke inside this window. So far, so good? Okay. We're saying it's a debilitating stroke if there is a visit that encompasses this stroke that lasted a certain day. So this stroke now becomes another index date. I'm making a little annotation saying like, this is a new index date that we kind of want to look for something. And we want to look for a visit that started, if this is the moment of the stroke, we were saying that we want the visit to start before the stroke and end after the stroke. That means that this visit spanned the stroke. So far, so good? Everybody understand how we're using the before and after? We want a stroke that has a visit that started before the stroke and ended after the stroke. What's the second thing we want to say about this visit? Duration is, yeah, exactly. So length greater than or equal to 7. All right. If we find somebody, they're out. If we have somebody that satisfies this rule, they're out, meaning this cannot happen. The number of times this happened has to be 0. And good point. We also want this. We want the visit type, not visit type, but we want the visit to be an inpatient or ER. Or should I say that? Is that right? Yeah, it's inpatient ER. Okay, so now we have the logic of what this is what we want to do. So let's do it in the actual tool. So we started with, we got that big S's there. Now we're saying, okay, now I want to base some other observation relative to the stroke. This is called a nested criteria.
So is the length of stay
The length of stay, yep.
Yeah,
Should be 7
yeah, should be 7 or greater than 7.
or greater than 7, yep.
Why 7?
Oh, that was just, it was arbitrary. We don't know what they didn't specify what a disabling stroke would be. So we're saying if they got the stroke code in the presence of an inpatient visit at a hospital or inpatient visit greater than 7 days, they were probably laid up. And so that's just what we're saying. And this is good to think about. You may have a better idea than this. I'd love to hear it, right? But this is just what we're going to go with for purpose of the demo. But you may have there may be other codes. Like you could do a measurement check that says and they were measured and it was like some physiologic measurement of them indicates disabling.
That's how you define disabling, right?
That's how I'm defining disabling, yes. I'm saying a disabling stroke is a stroke that would keep you in the hospital for in a hospital inpatient stay for 7 days. So I'm going to start with the stroke, and I'm going to add this nested criteria. It's the last one in the list if you guys are following along.
Sorry for interrupting you, but
No, go ahead.
if you look at the inclusion and exclusion criteria and eligibility criteria of any clinical trial, you will run into those kind of modifiers, disabling, incapacitating, whatever. So is there any kind of consensus as to how we define those kind of modifiers?
I haven't heard of any. I imagine it's a big problem.
Do you have any idea in sort of developing that kind of sort of
I don't, but we could evaluate cohorts using this phenotype evaluation to determine what do these people look like and how are they, what are their characteristics? And if that follows the mental model in your own mind about what that population looks like, if just only looking at disabling stroke, what is their care after the disabling stroke? What is it before? Did they get a cane? What could happen? But personally, for myself, I haven't studied that particular thing. I imagine these type of modifiers are common because you know what they mean by disabling, right? Disabling. When you're looking at a person in a prospective sort of setting in a clinical trial, you'll know if they've been disabled or not. You can actually kind of use your eyes to or ask them were you laid up? But when you're talking about observational data, this is one option of doing it observationally. I do not think that there's a consensus on how it can be done. Patrick?
So I would say this is a big opportunity for our community to try to reach consensus or at least common understanding. So to be clear, we're showing this not to say this is the way you should define this. We're just saying here is a way to illustrate how the tool works. But as a community, when we think about these types of issues, when we run into the question how should we define severe and disabling stroke, that's a question that I would encourage all of you, when you hit that point, let's ask the community, let's talk about it on the forums, let's share alternative ideas, and let's evaluate them so that we can hopefully identify one that becomes a best practice.
And Patrick, I think that would be a perfect subgroup in the phenotype library for
Absolutely. Yeah, so we need to be precise about when we use imprecise language like disabling stroke, we need to add the precision to say, what do we really mean by that? And then we need to have an implementation that tries to represent that idea as best we can.
Okay, so we're talking about this nested criteria. So I have my stroke and I now want to look for a visit. So I'm going to now add to this inner nested group. Notice how it's another and or kind of group thing. We want to look for the visit. Okay, so we're now looking for a visit. Any kind of visit? No, we're looking for inpatient and emergency room visits. Okay, so we got a visit of an inpatient. What about that visit? Well, it has to last 7 days. So the length of the visit will be greater than or equal to 7. So far so good. We have the length of that stay is defined. Now we have to say where that visit has to occur around. So this is going to be just pay attention to what I'm doing. If you're trying to follow along, just follow my leads here. So we're saying that the event that we're talking about here is the emergency room visit. The index of this particular event, the relative date that we're talking about, is the stroke. So we're going to say the event starts all days before and 0 days after the stroke. So the visit started sometime before the stroke. And then we're going to click this add additional constraint. And now we're going to say, and the visit ends between 0 days after and all days after. So we're basically saying the time window that we're going to look for the visit to end is from the stroke anytime after. That is what sets up that little bar being on either side of the stroke. This is tricky. Everybody got it though? Does it make sense? No, okay, that's fine. Go ahead.
So does that mean that the stroke needs to have happened when you were in hospital?
This is saying that you happen to have a stroke that corresponds with a period of time you were in the hospital. That's not exactly, like you're saying it had to happen in the hospital. It could have been that the observation of the stroke didn't record what the context of the diagnosis was. This is being a little bit more forgiving. You could say that it had to happen, like the stroke was associated with a visit. This is being a little bit more open, saying a record of a stroke was made and a corresponding visit surrounded that stroke. It's not exactly saying, and the stroke happened at the visit. It's just saying, coincidentally, there was a stroke and they were in the hospital for longer than 7 days. We're going to assume that means it's a disabling stroke. But it may not be exactly as specific or like you might say, like, I can imagine a case where that's not really doesn't mean what I think it means, but we're just using this constellation of data to define that.
So suppose someone had a stroke.
Mm-hmm.
They didn't even realize they had a stroke.
Okay.
And then a day later, or maybe later that same evening, they fell down and broke their hip.
Right.
And then they went to the hospital.
Correct.
And they were looked up.
So they would not have an observation of a stroke in that case, right? Because you didn't even know it happened, whatever. They fell down, broke their hip. There will not be an observation of a stroke in their data, so that person will not be found. Even though they might be laid up in the hospital for 7 days, they had a visit of length 7 somewhere in their history, but it didn't have the stroke recorded with it. So, am I getting to the crux of your thing? Like, did we get the right person? You might not. A lot of this is like a best estimate and a best effort to identify these things. Do we all agree that it is plausible that if you have a stroke coded with a visit surrounding it for 7 days, they were probably had a stroke and were disabled. They were out of action for a certain period of time. If we can all be confident and comfortable with that, then we'll use it. We'll use that. If there is another way we want to describe that, then we should find that other way. And we can evaluate in our cohort definitions using Phenotype Evaluator, what is the implications? Are we getting a lot more specific but not sensitive? Like, what are we giving up for these choices? These are just choices. Yes?
So if you were to check the checkbox for restricting the same visit occurrence,
Correct.
would it be stroke still windows with?
Good eye, yes. Absolutely. If we check this would be that the observation record that was recorded with this, there is a claims record that has the stroke coded to it. And in that, there is in the CDM an association between a condition and a visit. By checking that box, you're getting, basically to your point, more evidence that this stroke was actually associated to that visit, and therefore they were in the hospital because of the stroke. That's what that checkbox kind of does. Again, I'm making it a little bit more flexible because that relationship between the diagnosis and the visit sometimes doesn't even exist. So by requiring it, you could be missing something. But if you want to be really, really, really sure, then you could say that the stroke was actually the reason for the visit, and that's what that checkbox does.
Right, but you say that the visit has to start before the stroke.
On or before the stroke. Yep. If it was not, if I said after, like the visit happened after, then the bar would look like here's the S, and then we'd have this visit. And it is possible that you have this, they told you it happened 2 days ago, and I'm in the hospital now. That checkbox saying this kind of thing, like you'd say the visit can happen anytime, but I want the stroke to be associated to a visit. Why don't we do that real quick? And I'll show you, like, we'll let either of let's not do it now. We don't have time. Sorry. Anyway, to your point, right? By looking at the associated visit, you might not even care when the visit started relative to the stroke. You just want to know that there was a stroke associated to a visit that was inpatient that lasted 7 days. Boom. Like that could be an alternative way of describing that. Yes? I added a visit duration attribute to the criteria. So this box right here is we're talking about the visit. What is the characteristics of the visit that we'd want to include? You add this attribute and you have a choice of the visit length criteria. By clicking on that, that gave me the visit duration parameter. And I just said greater than or equal to 7. Yeah, you could add a lot more attributes to say the primary diagnosis was in primary position. Yes. So just to wrap this one up, I'm sorry. Yes, go ahead.
Why don't we bound the event end date here? Why do we keep it all days after?
Sorry.
Right down here where it says and event ends between 0 days after and all days after.
Right.
Why aren't we bounding it? Why aren't we pulling it back from all?
To what? What would you suggest?
7 days or something along those lines.
We could say 7. Oh, because if we said that the end had to be within the 7-day window, if we didn't say the end could be all days, we said 7 days. But let's say this visit actually spanned 31 days. Then you wouldn't find a visit that ended within 7 days because this particular visit ended 35 days later, you know? So you only want to say that you are looking for an end date that ended if you basically want to say the visit needed to be short. Like you couldn't be in the hospital too much longer after the stroke. But for purposes of what we want to do in this particular rule is we're just saying the end can be any time. And we're qualifying the visit that we care about has to be a certain overall length, but you could use these parameters to basically say, you're nodding your head, you think you get it, right? You can use these parameters to basically say, like, I care about when the visit ended. Whenever you say something other than all, you're actually saying, like, I kind of care when the visit ended. But we don't care about when the visit ended, really. We just care that it happened after the stroke. The visit ended after the stroke and started before.
Do you really need this additional attributes for the end date?
We could have we had 2.
There is already duration greater or equal to 0 to 7.
Correct. So I love it. We could have a stroke that had this little guy, that here's the stroke and here's the visit. Technically, it was a 2-day visit and it started before the stroke, ended after it, but that's not long enough for
It's not greater or equal to 7.
the duration. This is representing the duration. It's not greater than or equal to 7, so therefore this would not count as a disabling stroke because the person was not inpatient for long enough.
Are you asking why do we need the event end criteria?
Yes.
Because you could actually have a 7-day hospital episode that was like 2 years in the past.
Oh, yeah,
before.
Right. Okay. The second part of this is that we want to say, not only did they not have a severe disabling stroke, and they didn't have a recent stroke. So again, we're in this group, right? And we have this and here. So we have this disabling stroke defined, and we want to say and they did not have a regular stroke within 14 days. So I'm going to add to this group another condition, occurrence, that falls below this group here. And I'm going to just say no stroke. Sorry. What did I say? Yeah, it's there. There it is. Sorry. Eyes going blurry. So we're basically saying here, they also must not have the stroke between 14 days prior, right? That one was easy. So we have this no disabling for within 6 months and no any stroke within 14 days. If either of those things happen, they're out. Or in other words, 0 of those things must happen for them to be in. So thinking in terms of inclusion rule, 0 and 0. Now, I really only had one more to go, and it's kind of a rehash of the other thought process we had, but it dealt with measurements and conditions, and I think I'm short on time. Do we want to? Okay. So instead of you watching me click, I'm going to, I'm just going to pull up what this demo result is. And so that's here. Nope. Oh, you guys. No. Full? Okay. All right, so this full is actually all 16 of the criteria that you guys can look and see for yourself, but it also has the 5 from the demo that I was demoing. And so I wanted to show you the, yep, okay. Real quick, this is just going to touch on some of the things to be aware of when dealing with units in the CDM and lab values. So we are saying that they had to have no anemia and no thrombocytopenia, low platelet counts. So we are gonna, the easy one of this is just they did not have either of those two conditions, right? None of the anemia and none of the thrombocytopenia, okay? So definitely that's easy. The other one that's not so hard is how they are telling you to look for hemoglobin measures in the data. So in this particular case, when dealing with measurements in the CDM, you specify the value that you want to look for and what that value should be less than or greater than, and also specify the units of measure for that particular measured value data. So in this case, the hemoglobin was specified as either, like 2 ways we define this. We either said less than 10 grams per deciliter or 100 grams per liter, right? And that's just a matter of multiplying the liter to deciliter to get the 10 or 100, okay? So we had this like 2 ways of specifying pretty much the same measure that we're looking for, okay? So all I'm saying is that this is an example of using a measurement criteria using the unit and value attributes of that criteria. Yes?
Is there a way to save measurement criteria the same way you do a concept set?
No. So just to ask, they asked if like this is like we did the disabling stroke one, right? So you call it up in your head. It was really complicated. Wouldn't it be nice if we could just take that block and like save it so that if I want to then use disabling stroke again elsewhere in another cohort definition? Today, you'd have to copy the logic again. Like you'd have to restate the logic in the cohort definition. It's an excellent idea to be able to carve out the codes and the logic that's in that block and save that out and then reuse it. It would be a great enhancement, but it does not do that. Right now, you have to kind of do it again. Yes?
So it sounds like with the results, rather than taking the results and converting it to a common set of units internally, you have to recognize all the different units that might be utilized and put in each of those options.
Yep, and there is discussion.
Is there a plan to?
Yeah, there's discussion about standardizing units. Like if you're going to look for somebody's weight, do you have to say, I want to look for it in pounds and I want to look for it in kilograms and I want to maybe even look at it in milligrams because somebody's crazy and they decide to store it that way? Yeah, it's a real big challenge and it's just something. Now, there are features in Atlas that let you look at characterization of your measurement data, and you could pull up a concept and it would tell you these are the different units that have been captured for that concept of measurement. And for that specific data source, you could craft your cohort definition to work pretty well on your own data, right? But to your point, you go to some other location, even across a network in a different region, and they have different ways of recording these units, you are running into a challenge. So
This is an active area of research in the community. So Wojciech Husser is proposing a network study specifically to try to help people standardize their units and providing a recommended conversion tool that he's made available. And also Andrew Williams and Claire will be presenting tomorrow at the symposium about our new data quality tool that specifically checks to see how well are you doing against the units you've got. So this is an area of active research. The tool supports having as many as you want, but of course, if as a community we can converge on a smaller set, then that will make all of our lives easier, which is hopefully a task for those of you who are responsible for an ETL that you can take on board.
Yeah, but that is where I would prefer seeing it happen, absolutely. The ETL has a standard guideline. If you're doing these type of measures, this is how you convert it to this standard unit, and then you only need to know about that one standard unit when doing your criteria. That's how I would prefer it, but it's not easy. Okay, so, right, just gonna breeze through this. It's basically the two measurements that we're using in this criteria deals with the two different units. So 2 different values based on 2 different units. But in the case of the platelet count, we actually have the same unit, the same value, I should say, of 100, but it could be thousands per microliter, million per microliter, or 1,000 per cubic milliliter, right? Any of those guys would equate to like 100 is the value that we're looking for or less. Yes? No, so not at this time, right? But it would be nice if you could basically say, I want to use this cohort as like correlated, the criteria is to look for this cohort and use that. I won't go into some of the technical hurdles that I have in my mind for that, but yes, there is no way to basically go in and look at cohorts within cohorts. All right, everyone. Okay. So once you have defined everything and you want to see what results you can get out of your data sources, the generation tab shows what was found in your data based on these criteria. So at the top level, you'll have how many people were identified using your cohort definition. You might have a question like 13, that seems small, but there's only 1,000 people in the database. But if you want to get into more details about the individual inclusion rules, let's take a look at the 23 million. You click on View Reports on the right, and what it'll do is it'll show you a breakdown of each of the inclusion rules and how many people satisfied this. So at the very top, we had 247,000. See these total events? We had 247,908 warfarin exposures, okay? Apparently, because we have 247,908 people greater than or equal to 18, everybody in the data was greater than 18 who got warfarin. Okay, that's cool. But then you can see how not everybody had AFib. Not everybody had the prior AFib. Only 59% of those warfarin exposures would have qualified for the criteria of prior AFib, et cetera, et cetera. So is there anything here that you think we should? No? Okay.
Go ahead, no, take the time to explain what this is.
Okay. So each of these inclusion rules are captured independently of the target warfarin. It's not target, but the warfarin exposures. And so each of these numbers are independently calculated. So we had 240. So 100% of the people were age greater than 18. 59% of the people had the prior AFib. 83% were moderate or severe risk of stroke. Right? Each of these rules are independently evaluated for purposes of these percentages right here. It's possible that some of the people had AFib and the high risk of stroke, you know what I mean? That's not shown here on the left. You can find that on the right, but it's a little bit of a hunt and peck if you want to go and do that. So all I want to explain here on this report, primarily you're going to be interested in looking at what was the inclusion rule that seemed to have the biggest limiter factor on our recruitment or our inclusion in the study. So if we take a look at this, we'd look at the lowest number in the satisfied to figure out like which one was the biggest bottleneck, and it looks like that prior AFib was like the biggest limiter. We can also have a different view over here that will show you how, as you go through each inclusion rule, the criteria starts really whittling people around, and we can see that, like right here, we dropped off a lot of people. So as soon as we got to this severe disabling stroke, like that was here, but as soon as we got to no factors associated with increased risk of bleeding, we suddenly dropped. So something with the increased risk of bleeding would have a pretty significant impact on your recruitment, according to this particular view. Okay?
What is the meaning of the last column, the total events?
Oh, sure, absolutely. So the total events is, I started with your index events. You remember your entry events, your cohort index? Which actually I didn't talk about the exit in my cohort definition, and perhaps I should go back and do that. Okay. Well, anyway, the total events are talking about, this is the pool of people that were in your cohort entry. So in this case, it was just warfarin exposure. We could have moved the age into the warfarin entry event, saying they have to be greater than a certain age for their first exposure, and that in total events would have, they were all greater than 18s, but the point is that total events represents the total number of exposures at the beginning without talking about any inclusion rule. The matches is telling you how many people had all the inclusion criteria. So total is like what you started with, and matches is what you ended with. Note, however, this number pretty much equates to this 3708 here is this number right here. It's basically the people that got into your cohort. Make sense?
So what's important here is that when you define your cohort and you define each of the criteria, Atlas is going to provide you the ability to actually see the impact of those criteria and provide you a complete attrition diagram so that you understand what criteria you defined made an impact on the number of patients you recover. And here you can understand that this study of warfarin is only actually going to accept 14.93% of all warfarin users. So it allows you to assess the generalizability of the trial. Now that we know that 86% of the people who are taking the drug wouldn't qualify for the study, we can start to understand what that clinical consequence might be. I want to show the text too.
Okay. Also, there's a function that you saw that the UI was like obviously kind of complicated, but we also show the output of the cohort definition as sort of a print-friendly view, which is sort of like a read-only view that only has the text elements. There's no way to edit the cohort definition here, but that's good. You can use this to copy and paste into like a document. So you can see here that we have this inclusion rule, and the indentation indicates like this is what I'm looking for in the domain, and these are the attributes that I am looking for this. So for example, right, AFib, where the event is between all days before and 0 days before. Oops, looks like a bug. Index. And here we saw that very complicated one that had that very deeply nested group for the moderate to high risk of stroke. It's a little bit more readable here when we talk about like the age, the condition occurrences, and then the age of 65 with these other conditions. It's kind of like a little bit more easy to read, and it's just basically a lot more human consumption. This is what you'd want to show somebody saying, what do you think of my cohort definition? You don't necessarily want to send them over to the UI because there's a lot of stuff in there happening.
And the JSON.
Okay. Last thing I'll show you is that if you wanted to share this with somebody else, so you developed it and you want somebody else to see it, there is a way to get it from one instance of Atlas to another instance of Atlas. Looking at the export tab underneath the JSON, we see this is the kind of computer machine readable form of what that cohort definition is. You can copy it to a clipboard, and then let's pretend I am I'm on a different instance of Atlas, and I want to import their cohort definition into my own environment. You would do it like this. Okay. So we're going to make a new cohort definition. Okay. So we have this new cohort definition. It's completely empty. Makes sense? So, but I have in my clipboard the content of what that other cohort definition was. So you go into it, you go into the export tab, and you'll see like, here's my empty cohort, and I want to basically overwrite it with the content of my other cohort. So I'm going to highlight everything and paste. And then if I click reload, my definition will now have everything that I had in that other instance. This is pretty much the primary way we talk about sharing. What we'd rather have is more of a curated cohort definition repository that basically lets you go in, navigate, browse, and then import into your own instance. But this is how you do it. Yes?
So can you actually view the data? Once you come up with the numbers, there are like 100,000 patients that match this criteria. Can you see the patient chart?
Yes, absolutely. There's other functions which is a little bit beyond the scope of this, but you can do a characterization analysis on it. That's this characterization navigation right up here. And you can ask for what were the comorbidities and concomitant medications that were as of the index just among this population.
Is it per patient? Like how would you link it back?
There is a patient profile tool that, given your cohort, it'll let you randomly navigate through like the next patient, and it'll give you all their patient level data. And it's something that some environments you'd want that enabled and let people go into the patient level. There's a configuration atlas that lets you kind of disable certain elements. for PHI purposes. You know what I mean?
So there is an option.
There is a function. Yeah, there's a function. There's two modalities of what I'm describing. One is a sort of a summary statistics at the population level, like the table 1 that Patrick was describing. You can generate a table 1 once you have your cohort definition. You can also use the patient profiles, which is this profiles function. Given a cohort definition, it'll let you go through one at a time and see what their detailed patient record look like on a timeline. And I'm sorry, we don't have a lot of time to go through that, but I'm doing a demo tomorrow for Introduction to Atlas during the symposium, and I'm happy if you come up and say, I've never really seen that. Can you show me something? And I can pull up a profile and just show you some stuff.
Can you share the JSON file with us?
Yeah, I will export this, and actually do you have internet? You can go to this Cohort Odyssey. You can go to Cohort Odyssey tutorials, amazing, this link, and it's number, sorry, let me kill this because we don't need a copy. You can go to 25, number 25, cohort definition 25. So should we send out a link or something?
It's just in the, just search for Odyssey 2019 Warfarin full.
Yeah.
And you'll have that, and you can grab the JSON.
Let me go ahead and, so if you're looking at your cohort definition list and you just type full as a search, because I think this is there's two actually, but one's my copy. You have this Odyssey 2019 Warfarin first exposure full. You go into that, you can find the JSON. Okay, everybody, I appreciate.
So the thing I want everybody to understand about what Chris is showing here is in Atlas, you have a tool that's helping you to define your cohorts. And you can go through and click through, and hopefully you now understand that it can be a simple logic or it can be as complex as you want it. It's pretty much any Boolean operation on any field, anywhere in the entire CDM. But that tool is not just a user interface to make you or help you think through the design. It's also a tool that's providing you a textual description so you can provide it a complete, transparent reporting of what you've done. And it's a computer executable file that turns into SQL code that executes against any technical environment in the Odyssey community. So what that means is now you guys have a tool that is publicly available on the Odyssey website and that you can download and install locally in your environment. So now you can create cohorts. Whether or not you have access to patient level data, you can create cohorts and ask questions of the world's data now. And you can do that by writing a protocol, implementing code through the tool, and sharing that with others to be able to ask questions. And I hope that as the rest of the day, you'll be thinking about what cohorts you want to create. And as you learn about the other analytic capabilities in the tool, you'll start to think about what questions you want to ask using your cohorts and what evidence you want to generate to answer clinical questions.
So I'm a newbie here, and I have to say I'm very impressed. Kudos to you guys. This is awesome.
Thank you.
Aw, thanks. Okay. All right. I overwent my agenda. Sorry about that agenda flub there.
So we're gonna just change up a little bit. We're gonna take a break for lunch right now.